first workshop that we're doing between the School of Public Health, JMSC, and others who are involved will be introduced. And I say specifically this is a workshop because I just wanted everybody to understand, all of our journalist friends to understand that although you might recognize a lot of these names and faces from seeing them being interviewed all the time in the press and on television, on BBC and CNN, this is not a press conference. This is not a press briefing. This is actually what we call a workshop, or it's a chance really to kind of help the journalist increase their literacy skills on issues involving public health. And I'll just tell you a little bit about why our involvement as HKU journalism. It actually just this actually was birthed out of a panel at the Foreign Correspondents Club that myself and KG were sitting on with a correspondent, a reporter covering the COVID issue from the South China Morning Post, who actually approached us afterwards and said, you know, a lot of journalists were thrown into this huge public health issue without really kind of having studied anything about public health or having kind of public health literacy. You know, I mean that in the sense of not having really been versed in kind of these very complicated topics, and all of a sudden, you know, journalists who might have been doing something totally different, you know, in December may have been covering protest or something else, or suddenly having to become experts on pandemics and epidemics and what does flattening the curve mean, and you know, what does asymptomatic mean, et cetera. So you know, and we hear a lot of various kind of opinions coming out of various things. I mean, it's going to be, you know, 20,000 dead. No, it's going to be 4 million dead, or, you know, all of these various things. And it can be a bit confusing. It can be a bit confusing, obviously, for readers, but it can even be more confusing for the journalists who have to keep track of these things and know what's a reliable source, what's not a reliable source. How do I treat this information? How do I treat something that's considered modeling, et cetera, et cetera? So the journalist who approached myself and Professor Fukuda just asked if we could put on something like this, which would be a workshop on public health reporting for journalists. So that's kind of what this is. So and again, if this works, if at the end of this, we'll be taking a survey. If this works, this might be something that we might, you know, kind of try to establish on a more permanent basis. Because when you think about it, we teach courses on how to report about China, how to report about global affairs, how to report about economics. We have business reporting courses, but at the moment we don't actually have a course on public health. And I think what this last 3 months or 4 months have shown us since the advent of the coronavirus is how important it is to have journalists who are versed in the language and the experts and know the experts and know the expertise of public health reporting, so we can then accurately report that back to our readers and viewers. So without further ado, we're hoping we can get in Thomas Abraham, who actually was a teacher here at Hong Kong U Journalism before retiring on to India, but we're going to try to drag him out of retirement. He's been helping us out a lot on this. He helped put this together in this format. And we've got some great participants here who mostly I'm not going to introduce, but I will introduce Keiji Fukuda, who's the head of the School of Public Health here in Hong Kong. He's no stranger to Hong Kong, and he's no stranger to these kind of public health emergencies in Hong Kong. In fact, he and I first met during the bird flu epidemic, which was in 1997. So yes, I'm dating myself. And so, KG has worked with the WHO. He's he's in Geneva. He's worked with the Centers for Disease Control. He's out here now. We're really lucky that we've had him here now at the time of this tragedy going on, and which actually started in China and has badly affected Hong Kong. So KG, without further ado, I would like to step back, introduce you, let you introduce your team here. And then I'd just like to a couple of housekeeping things, please. Please keep your microphones muted so we don't pick up your background noise. If you can keep your cameras on if you want, or you can turn your cameras off if you want, if you're in the audience here. We're going to be going through a couple of presentations here. And also, this will be an on-the-record workshop, but just keep in mind, we'll be showing you some slides. The slides might have images that are copyrighted, et cetera. So if you're going to be using any images of the slides, you might need to get permission for that. But anything that we say in this workshop is on the record, and it's also available on YouTube. And again, you feel free, if you're in the audience there listening, you don't have to have your cameras turned on, but please do keep your mics muted. I know some of you have already told me privately that your cameras are turned off because your house, you're making breakfast, or your apartment doesn't look nice. We don't care about that. But without further ado, KG, shall we get rolling? And hopefully Thomas will come in and join us later.
Great, thanks, Keith, and thanks everybody for joining. As Keith mentioned, this is the first time that the JMSC and the school have done something like this, and we're really pretty excited. And actually, it's great to see everybody's name on the screen and see some faces of old friends and colleagues. But as Keith mentioned, this came about because Elizabeth from the South China Morning Post had really discussed this idea with us at lunch. But personally, part of the reason why I was so excited about this idea is from personal experience. When I was at CDC, the night fellows were there, and some of the people who train there, really have become lifelong colleagues and friends. And that experience in which we had journalists embedded at CDC really fundamentally changed my thinking about, the relationship between public health and journalism. And it's only gotten stronger over time. I mean, in essence, I now see journalists as that group of people who really ask the questions which need to be asked. And it's the group of people who chases down the answers, even when it makes it uncomfortable for everybody, and provides a kind of balanced viewpoint of the world. And I think this is really important to support. And so it's one of the reasons why, I'm personally so excited about this idea. Now, as Keith mentioned, this is not a press conference. We're going to, of course, be talking about COVID-19 and the SARS-2 coronavirus, but it's fundamentally about trying to equip everybody to ask better questions, ask right questions, and know when you're getting, reasonable answers and so on. So as Keith mentioned, to build up everyone's health and scientific expertise in this area. And so to help do this, we have a panel of speakers who you have seen all of their names, but as you probably recognize, this panel is about as good as it gets. Each of the speakers today and each of the people who'll be talking and you'll have a chance to ask questions with is eminent, very well versed, and they are deeply active in the current outbreak as they have been in other outbreaks in the past. And then finally, as Keith mentioned, afterwards, we would love to hear, Jennifer's going to be reaching out to find out what you thought about this. But if you think it's worthwhile, if you think that there's things that we ought to change or modify, we'd love to hear about it, because it is something that we could do to cover a variety of different topics if it's helpful. So, the first up, I'm just going to introduce everybody in one swoop, so I don't break up the presentations and the flow of questions and answers. But we're first going to hear about the epidemiology of outbreaks, and we're first going to hear about viruses, and that discussion will be given by Professor Malik Perez. And so Malik, as probably all of you already know, is one of the most famous virologists in the world, and he's really focused on influenza, coronaviruses, and other emerging infectious diseases in his career. And his work has been fundamental to our understanding of things such as avian influenza viruses, the 2009 H1N1 pandemic, and then more recently the coronaviruses like MERS and COVID-19. But I think all of you will also know that he really led the team that discovered the SARS virus back in 2003. We're then going to hear from the epidemiologic characteristics of outbreaks, some of the features, and that discussion is going to be given by Professor Ben Cowling. So Ben is the head of the Division of Epidemiology and Biostatistics in the School of Public Health at HKU. And he's also the co-director of the WHO Collaborating Center for Infectious Diseases, Epidemiology, and Control, which we have at the school here. But the body of his work, he's really world famous for his epidemiologic work. Much of this is focused on influenza, and much of this has focused on the transmission properties of respiratory viruses. The third talk that you're then going to hear about is about diagnostic tests for these kinds of pathogens and the development of things like vaccines. And this talk is going to be given by Professor Leo Kuhn. So Leo is also in the school. He's a molecular virologist with a very wide range of work going from the basic virology of RNA viruses to the development of molecular diagnostic tools and vaccines. And much of his career has focused on influenza viruses and coronaviruses. Leo has been deeply involved with the development of molecular tests for pathogens like SARS. He's working on influenza vaccines and different platforms for that. And again, has been focusing much of his work on MERS and the current SARS coronavirus too. After Leo, we're then going to hear from Professor Joseph Wu on mathematical modeling and models for outbreaks like this. Joe has specialized in mathematical and statistical modeling for his career, and particularly on infectious diseases and their interventions. His work has been instrumental for developing disease control and policy interventions for several diseases, including coronavirus. And Joe also opened up the first massive open online course or MOOC entitled Epidemics. And so this has been quite popular worldwide, and we've had, I think, over 16,000 people enrolled in that course. And then finally, to help wrap it all up and help us navigate in this quite complex ecosystem of rumors and information and misinformation, we have Dr. Masato Kajimoto. Masato is an assistant professor of practice at HKU in the Journalism Media Studies Center. And he specializes in news literacy education and the misinformation ecosystem in Asia. And then before becoming an academic, Masato is also a working journalist and, for example, worked for CNN and others. So with that as an introduction to the panels, let me, Malik, if I can turn it over to you for the first talk. Or Jennifer, is there any other things that you want to raise before we move into the talks?
No, I think we're good here, KJ. I think we can move on.
Okay, thanks, Keith. Malik, if I can turn it over to you then.
Okay, hi, good morning. I'm just trying to share my screen, Jennifer. It seems that
Yes, Professor Malik, sorry, Professor Paris. Yes, I think we're having some issues with that. I will show your PowerPoint for you right now, and I will just follow your cues.
Okay, so maybe let's have the title slide.
Yes. Can everyone see this?
Sorry, that's Ben.
That's Ben's?
That's Ben.
Okay.
Ben, do you want to go with this? And
No. I'll just move it down to yours. My apologies. I got it. No problem. Oops. Sorry. Almost there. Yes. Is that good? Can everyone see it?
That's good. Thank you.
Okay.
Yeah, so good morning, good evening, everybody. So I was asked to basically give an ABC of viruses. Now, this may be pretty obvious to a number of you because I see some very eminent journalists logged in, but it is probably not obvious to some of the journalists who are suddenly asked to cover problems like COVID-19 and public health issues. So if you go to the next slide, I will just, the next slide, please. So can I, yeah. So I just, some of the things I will cover is what is a virus? How do viruses differ from bacteria? What coronaviruses infect humans and where do they come from? And also why there are more new virus infections emerging to cause outbreaks like this. Next slide. So what is a virus? So you just see on your left-hand side, you actually see a coronavirus particle. And on the right-hand side is a schematic. And essentially what you see, a virus is a packet of genetic information that you see right in the heart of that image. And it can be DNA or RNA. Now, this genetic information, if it is not protected, it will be soon degraded. So it is covered by a protein coat and sometimes by a viral envelope. And what you see on the left-hand side is an electron microscopic image of coronavirus. And you're just looking at it from the outside, that is looking at the envelope of the virus with these spikes sticking out, which is quite characteristic of coronaviruses. So the size, the shape, and this appearance is characteristic of a coronavirus. The next slide. So yeah, I think we can carry on to the next slide. Yeah, so if you compare a virus with a bacterium is much more complicated form of life. It is self-sustaining. It's an independent life form. And if you go to the next slide, so we can just compare, bacteria and viruses. So if you think of a human, we have more than 20,000 genes. So that is packets of information that control so many of the activities that we do in our cells. Now, if you look at a bacterium, it is not much less complex. Many bacteria have around 4,000 genes. So it is, although it's a single cell, it is very complex. You go down and look at a virus, you can see how little genetic information there is. So really, viruses essentially cannot do many things by themselves. And that comes back to a fundamental question of dealing with viruses. And we'll come back to that later. And obviously, of course, a matter of size. I mean, bacteria are about 1,000th of a millimeter. If you remember that what we can see with our naked eye is about 1 millimeter or a bit smaller than that. So bacteria cannot be seen with the naked eye, but can be seen with a light microscope. But viruses are even smaller than that. So they are small in size, but they're also small in the amount of genetic information they carry. And the next slide. So what this implies, as I said, is that with such a small amount of genetic information, a virus cannot do all the things it needs to do. It has to use another living cell in order to, and get that cell to do everything for it. Basically, the virus enters a cell. It can be a human cell, a plant cell, even a bacterial cell. It takes control of the cellular mechanisms and essentially directs the cell to make more copies of itself rather than do the things that the cell needs to do. So clearly, this process can lead to dysfunction of the cell, the death of the cell, and that is ultimately what leads to disease. Next slide. Now, something that sometimes many people get very excited about is mutations in viruses. So what you see on the left top hand corner is a strand of nucleic acid being copied. Normally, when one strand is copied to another, there is a very accurate copying system. And particularly when DNA is being copied, as in a human cell or even a bacterial cell or some of the DNA viruses, there is a spell check type of mechanism. So as the copying goes on, there is a continuous checking to see whether the copy is accurate. If there is an error, there is an error correction mechanism which goes back and makes sure that the copy is accurate. So that is when DNA gets copied. But when RNA viruses copy themselves, this spell check mechanism is not so effective, or some of these viruses do not have this spell check mechanism, which means that you do have random errors that can be introduced. And so therefore, there is kind of a swarm of genetic mutants in RNA virus populations. Having said that, the coronaviruses, although it's an RNA virus, does have some form of a proofreading or spell check mechanism. So the mutation rate of coronaviruses is not as high as with other RNA viruses, say, for example, like influenza or HIV. The next slide. So what these mutations of a virus practically involve is shown at the top right-hand side there. So you can see, for example, in gray are viruses that are susceptible to an antiviral drug. But within this swarm, you do have some mutants there in blue. And as soon as you start using the antiviral drug, you select the viruses that are resistant. So you can see that these blue ones now dominate, and therefore the virus becomes resistant to the drug. But this is not just for escaping antiviral drug therapy. The same thing applies to escape antibody pressures. For example, you have heard about influenza virus escaping the immunity of the population every 2 or 3 years and causing antigenic variants. And it's also true when a virus crosses from one species to another, because the virus has to adapt, make some major changes to adapt to the new species. So this mutation is quite important in a number of aspects of virus behavior. The next slide. Now, coronaviruses, of course, they have come to attention for the first time in 2003 with SARS. But as you know, there were human coronaviruses known before. Those were the 229E virus and OC43 virus. And they were the causes of the common cold. So nobody took much notice of them until SARS. SARS, of course, brought a lot of attention to coronaviruses, and that led to the discovery of a couple of other coronaviruses. One is Hong Kong U1, and the other one is NL63. Both of them can cause respiratory disease, but they're not so lethal in that sense. But SARS jumped from animals to humans, caused an epidemic. As you know, MERS, again, crosses from animals to humans, sporadically causing outbreaks. And most recently, of course, we have COVID-16 or the SARS coronavirus 2. But the important point is that many of these viruses have come to humans from animals. Obviously, SARS, you know, came to humans from bats. And you know that MERS comes to humans from camels. And this most recent virus, the SARS coronavirus 2, has a bat ancestor. And then there are other animal hosts, such as pangolins, that are being discussed. But what is interesting is that after all this attention on coronaviruses, it was realized that even the common cold viruses, such as OC43, came to humans just within the last few hundred years and originates from a bovine, a cattle coronavirus. And the 229E, which is another common cold virus that we had known about, again originates in bats and may have come to humans again through camels. So this business of crossing species is a regular trend with these coronaviruses. Next slide, please. Yes. So then we have a number of terms that we use. So when somebody is infected, there is an incubation period during which time the virus is replicating, but there is no obvious disease. And then clinical disease appears. It may be fever, cough, depending on the disease that is caused. Now, of course, the virus is replicating right through this incubation period at very low levels, and gradually it increases. And quite often, there may be virus being shed, if it's a respiratory disease, from the upper respiratory tract, a bit before the symptoms appear. Then, of course, virus shedding increases, and then the patient develops an immune response, this antibodies response, a cell-mediated immune response, and the virus replication is controlled. Now, in the case of COVID-19 or the SARS coronavirus 2, it is clear that virus can be shed for at least a short time before clinical symptoms appear. And this, of course, has been a source of a lot of attention as to whether patients are infectious during this time. And sometimes, of course, this clinical disease may not be so obvious. It may be less and less obvious and even asymptomatic. So you can go through this phase with no obvious clinical symptoms. And that is what we are talking about when we talk about asymptomatic shedders, for example. Another issue, of course, is once the patient is recovering, the viral quantity is coming down. But in the case of SARS coronavirus 2, the virus shedding can continue for quite a long time, sometimes 3 weeks, 4 weeks, at least detectable by PCR. But whether these patients are infectious or not is another important question, because the question is whether patients who have recovered clinically, even though they may be PCR positive, can be discharged safely into the community. And this becomes important because there's increasingly a pressure on hospital beds and isolation beds. The next slide, please. Right, so again, this question of quantity of virus, in this case, we are talking about respiratory disease. In the case of SARS, it had a very unique pattern. So you can see this diamond that is there, which means in the first few days of illness, there was actually very little virus being shed from the upper respiratory tract. This virus load peaked at about day 7, day 8, day 9, and then, of course, the immune response controlled the virus infection. So what this meant is that SARS was not so infectious in these first 4 or 5 days after the symptoms developed. And again, what that meant was that if patients could be identified earlier and earlier, once diagnostic tests became available, you could essentially stop transmission purely by identifying and isolating patients. Next slide, please. Now, if you look at influenza, the pattern is very different here. What we have in green up here, the amount of virus being shed in the upper respiratory tract is high right at the time of developing symptoms, or even maybe a half a day before. So what this means is that these patients with influenza are infectious right from the time they develop symptoms, maybe even half a day or so before. And unfortunately, COVID-19 or SARS coronavirus 2 is behaving more like influenza than like SARS of 2003. And that is why the measures that were used, the public health measures that were used to control SARS, it is much more difficult to stop this transmission because patients can be transmitting more or less from the time they are visibly symptomatic. The next slide. Right, so this is actually work done by my colleague Leo Poon, and it's out online recently. It's the question of how stable is this SARS coronavirus 2 in the environment. And I have just kind of very simply summarized. I mean, the detailed information is there on the paper, which you can look up. And what is quite striking, and this was also true for the SARS of 2003, that these coronaviruses are extremely stable in the environment. So you can see that, for example, on plastic or on stainless steel, it can remain quite viable for up to a day. And if you have a very high dose of virus deposited on these places, it can remain, still some infectious virus can remain for 2 or 3 days after. And particularly important, this last bit here, the outer layer of a mask, a surgical mask. And you can see that if infectious virus is deposited on the outer side of the surgical mask, that can remain infectious for many days. And this is exactly why it is very important that if you are wearing a surgical mask, you don't touch the outside of the mask, because you will then contaminate your hands. And if you touch your eyes, you will be transferring virus to your eyes. Next slide, please.
Well,
finally, the question
of Malik,
treatment.
Can somebody unmute? There's somebody else talking. Jennifer, actually, I think you might be unmuted now.
Okay, so let me continue. So as many of you are aware of antibiotics, we have hundreds of antibiotics which are used for treating bacterial infections. So why don't antibiotics work for viruses? And the answer is there in this image. As I told you, a bacterium is an independent, self-contained organism. So there are many targets you can shoot at in a bacterium to stop it replicating or to kill it without harming the patient who the bacterium infects. But because viruses replicate inside human cells, that is, I'm talking about human viruses, most of the mechanisms it uses for replication are essentially mechanisms that the human cell needs. So, of course, you can kill a virus quite easily. You can boil it, you can put it in formalin. But if you put a patient, if you boil a patient or put the patient in formalin, you will certainly kill the virus, but you will also kill the patient, and that doesn't help. So that really means that we have to be much more clever in identifying targets that will stop the virus without affecting or being toxic to the human cell. So if you go to the next slide. The next slide, please. Yeah. So I've just given some examples of where in the replication process, so the virus has to attach to the cell, it has to get into the cell, it has to uncoat its nucleic acid, it has to start making viral proteins, make new viral nucleic acids, and then these two have to be put together again, and new virus particles have to assemble and leave the cell, and finally these new virus particles have to escape this infected cell and go and find new cells to infect. So for example, the oseltamivir, the drug that, that is used to treat flu, essentially blocks at this last stage. It prevents the virus that has been formed escaping the infected cell. Now, some of the drugs that are being talked about now in regard to coronavirus 2, for example, remdesivir, lopinavir, they essentially target the viral nucleic acid replication process. Chloroquine is, again, something that has been talked about. It essentially blocks at a number of steps, but also including this uncoating process. So this is the reason why it is much more difficult to find good, effective antivirals that are not toxic. The next slide, please. And then, of course, we have the issue of how do we know that a drug works? So, for example, what you see here is you have a group of people, you start them with a drug, and you can see that a couple of people have recovered. So that looks good. But the next slide. But you can see that if you had not treated the same group of people, maybe the same number of people might have recovered. So this is why just getting excited about a drug just because it works in the test tube and you use it in patients and a few patients recover doesn't mean that that drug is working. And that's why the concept of a randomized controlled clinical trial becomes so important. The next slide. So you might actually, what you hope to find is that with your drug or your intervention, more patients recover, and you need to make sure that that is statistically significant and not a matter of chance. The next slide. But sometimes you might actually see that the patients who are treated do worse, and that's why controlled clinical trials are important. Now, what you see here is a recent publication that is out in open databases. So this just illustrates the numbers of people who are in clinical trials for various interventions for COVID-19. So you can see drugs like oseltamivir are also being used. And in fact, favipiravir is also a hot topic, but I must say that there is no evidence that either of these drugs, that are basically designed for influenza, that they work on COVID-19. In fact, in our own laboratory, neither of these drugs work, at least even in the test tube. Then, of course, you have we have the chloroquine we talked about, lopinavir, remdesivir, etc. Next slide. I think that is probably my last. Yes. So thank you for your attention, and we'll be happy to take questions now or later.
Hi, everyone. Yeah, as you can see, we've had a bit of some technical difficulties this morning. So Keith Richburg and I will take over the Q&A. And instead of what I had told you guys to send me the PMs for your questions, because we've had to do this, would you please just go ahead and send your messages to the group chat, and Keith and I will go through them and we will put them to the speakers. So let me look at what's going on right now. We've got several questions that are for later. There's a question from Dennis. Dennis is asking if there's any chance that this new coronavirus might adapt to humans by becoming less lethal but more widespread.
Well, I mean, it is quite widespread at the moment.
Already. Yeah.
You know, I mean, it is transmitting quite efficiently, right? I mean, when we have been talking previously about things like H5N1 and avian flu H7N9 and things like that, the question has been, yeah, it jumps to humans occasionally, but it is not adapted to transmit in humans. This one is doing that very well. Now, I think what is underlying that question is this concept that viruses become less virulent and more transmissible over time. Now that may be the case, but you see, from the virus's point of view, it doesn't know that it is causing disease. I mean, all it's trying to do is to replicate its genome and to perpetuate itself. Now, disease is essentially a side effect of this strategy of the virus to somehow survive. So severity may not necessarily be linked to transmissibility. Having said that, for respiratory viruses, obviously a virus that replicates in the upper respiratory tract is much more likely to be efficiently transmitted than one that goes deep into the lungs and not in the upper respiratory tract. For example, H5N1 is an example of that. So that did not transmit well because it was not in the upper respiratory tract. But so viruses, of course, may adapt further, but I must say that, I mean, this virus is doing a pretty good job already of transmitting, and it is severe enough. So yeah, it may adapt further, but I think we have enough problems to deal with that as it is.
Malik, this is Keith here, and I've got another question coming in from Elizabeth Chung from SCMP. Two questions actually for you. He says, first question is, how exactly should one understand the concept of viral shredding? Does this mean the period when an infected person could spread the virus to someone else? Just that term viral shedding. And the second question was, if coronavirus mutation rate is not that high as influenza or HIV, does that mean it's likely that a vaccine can be developed that would be valid for life rather than like influenza where you have to go get a jab every year?
Okay, thank you. So what we mean by viral shedding is that the virus can be detected in either in the respiratory tract, that means, you know, in the nose or the mouth. So that's a portal of exit for the virus. For other viruses, you can have viral shedding from the feces. I mean, coronaviruses also, I mean, even the SARS coronavirus 2 can be detected in the feces, but it is not clear that it is infectious by that route. So what we talk about in terms of viral shedding is the period during which the virus can be detected. And nowadays, when we talk about detection, it is by this method called PCR, which is extremely sensitive. Now, there is one point to keep in mind, and that is detection of a virus by PCR may not necessarily equate to infectiousness, because usually when we talk about viral shedding, we mean can we detect the virus? And as I said, the virus can be detected in patients with COVID-19 for 2 weeks, 3 weeks, 4 weeks, even sometimes after they have recovered. Now, that does not necessarily mean that patients who are in their 3rd week of illness are necessarily infectious, because what has been found is that we can no longer culture or grow the virus. So infectivity is probably reduced. So you do have to keep in mind these two, different concepts. I mean, with shedding, we are really talking about being able to detect it, usually by PCR. Transmissibility, of course, practically what it means is, can one person transmit to another? But you cannot, you don't want to do that experiment. So culturing the virus is the next best surrogate that we have as a better indication of infectivity. Over. Sorry. The next question is about vaccines. So the mutation rate being lower, and is the virus more stable? Actually, I think there's very good likelihood that vaccines for this coronavirus, or even for MERS, for example, would be effective. And this is for two reasons. One is, when I say effective, they will be effective long term. If they're effective at the start, they're probably likely to remain effective, unlike flu, where the virus is changing every year and you have to make a new version of the vaccine. And the reason for that, as was indicated by the question, because the mutation rate is lower, is one thing. But the second thing is that what we can see is that the protective immunity to this virus, as well as MERS, is targeted at exactly the site at which the virus binds to the cell. So which means the virus cannot afford to mutate that site. And this, we have seen this in MERS. As you might know, MERS is found in quite a wide geographic area, not just in the Middle East, all the way in Africa. And all those viruses, although they may be genetically different, they all essentially are neutralizable to the same extent. So that is a bit of good news, I suppose, although not in the immediate horizon because we don't have a vaccine. But I would say that if we do develop an effective vaccine, it is likely to be long-term. Over.
Okay. We got a question from Helen Branswell, Stat News. Would you expect the virus to have to mutate in any significant way anytime soon? There are so many susceptibles. Why would it need to?
Exactly. I mean, I think, at the moment, the virus doesn't have any pressure. There's no need from the virus's point of view to undergo any significant change. So there is no pressure on the virus to mutate. I mean, the pressures will come with herd immunity developing, for example, more and more people becoming immune, and then the virus will have to see if it can evade this immunity. But as I indicated, that may be quite difficult for this virus, unlike, say, for the influenza virus. The second type of pressure will be once there's an effective antiviral agent and that is being used, then again, there may be pressure for the virus to move. But as Helen pointed out, I think in her question, at the moment, there is really no urgency for the virus to mutate, to adapt any further. But having said that, I mean, although the mutation rate is lower, being an RNA virus, it continues to have a slow rate of mutation. But it doesn't necessarily mean that these mutations are functionally important or that they are making the virus more or less virulent or transmissible. Over.
Let's see, we've got one more, we'll take one more question here and then we've got to move on. Someone is asking what is the real infectious period after the onset of symptoms, and specifically when the virus confirmed cases of COVID-19, if you're still test positive, but you no longer have any symptoms, you've recovered, can you move on to go back to home and you're basically no longer needed to be in isolation? Can you explain any of that?
Right. So I think I alluded to that at the early stage. So many patients do recover within maybe a week or 10 days. They are fully recovered, but certainly at the early stage of this outbreak, because of an abundance of caution, before patients were discharged, they had to be tested on 2 separate days and tested negative on 2 separate occasions before being released back into the community. But as I pointed out, sometimes patients have recovered, but they're still shedding virus that is detectable by PCR. But this virus cannot be cultured. So I mean, you know, there's a nice study from the German group led by Christian Drosten, where he looked at a small cohort of people, and after day 9 after infection, you could not culture the virus, although you can still detect virus by PCR. So one of the big questions really right now is to resolve this question of infectivity, because there's a urgency to be able to discharge patients home even before their PCR becomes negative. And I think that is very likely to be the case, but you know, still there is no absolute guideline on how we can do that. Over.
Okay, everyone, we're gonna move on to Professor Cowling now, and if we have time at the end, we can put your questions to Professor Paris at the end. So here we've got Professor Cowling.
Can you see my slides?
Yes.
Yes, Pam, you can see your slide.
All right, great, I'm here. So thanks, I just got probably 15 minutes to go through some basics of epidemiology, what's being measured, what's the epidemic curve about, and some other kind of issues, and then getting to containment versus mitigation and how to measure success. First point, in any epidemic, there are going to be more infections than there are cases. So in order for someone to be counted as a confirmed case, for example, one of the 680 confirmed cases in Hong Kong, however many it is today, in order for that to happen, someone who's infected must first develop symptoms, then go to see a doctor or hospital, then get tested for the virus, and then have a positive test result. Actually, for some people, there's a caveat. If they're under close observation, maybe in quarantine, they might be tested even without symptoms and without having to go and see a doctor. But in general, those 4 steps are the processes, and that's a kind of filter. So actually, some people who are infected in the community won't develop symptoms. Others who develop symptoms may not go and see a doctor. Their symptoms are not too serious and they'll recover. Even if they go and see a doctor, some people might not be suspected that they're infected and then might not get tested for the virus. And then even if they are tested, we know that some of these PCR tests have imperfect sensitivity. It means even you've got the person in the hospital with the infection, you test them, but it comes back negative, not positive, and then they're not counted as a case. What does that mean in practice? It means we need to be very careful when we talk about cases that we're not also saying that that's the number of infections. For example, in Hong Kong, there's certainly more than 680 infections. I think it's 680 today. There's always going to be more infections than that. We don't know how many more. It depends a little bit on how aggressively a particular place is looking for infected people, how aggressively they're testing, and so on. So when we compare case numbers between different countries, we have to be very careful. For example, the case number could be higher in one country than another. It doesn't mean there's more infections in the first country. A better way to look at it might be to look at perhaps among severe cases in intensive care or fatalities. But even then, there's testing differences between different places. I know in some countries, they won't even test fatal cases after the deaths occurred because they don't consider it's useful. In other countries, they will. In the post-mortem, they'll do a coronavirus test. So they'll have more coronavirus deaths because of that in their data. What's the implication of that? So my colleagues have and I did an analysis of the case definitions that changed over time in China. Now we're on the 7th definition of coronavirus cases in China. And this medRxiv paper, the reference on the next slide, shows how the case definitions evolved. In version 1 in mid-January, there was really a lot of requirements for someone to become a laboratory confirmed case. They had to have a very clear link to Wuhan. They had to have a fever. They had to have low white blood cell counts. They had to have radiographic evidence of pneumonia, and they had to have failed 3 days of antibiotic treatment with no sign of improvement. So they had to have all of those things. And then this orange one, they had to have a sequence that was the same as the SARS coronavirus sequence. So they need to tick every one of those boxes. You see at the bottom here, we got the things they need to tick. 1 green, blue, 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 and orange. And if there were some other people that didn't tick all those boxes, they wouldn't be a confirmed case of coronavirus. As time went on, you can see the requirements getting a little bit looser. So by the end of January, the 4th version of the case definition, you need 1 green, 2 blues, and an orange. And so 1 green, there's a few different choices. The 2 blues, there's 3 choices. You need to have at least 2 of them. So either a fever or low white blood cell count or radiographic evidence of pneumonia, at least 2 of those. And then you need the orange as well, which at that point could be a PCR positive. And as time went on, the case definitions got broader and broader. In practice, what does that mean? When we look at the epidemic curve in Wuhan, and this is an epidemic curve on a log scale, I'll show another epidemic curve in a moment on a regular scale. So the y-axis is going from 1 to 10 to 100 to 1,000 to 10,000. The blue dots are the cases under the first definition, red is under the second, yellow under the third, black under the 4th, and then the 5th. We skipped the 3rd because it was very brief and it was about severity, not only. What we see is we expect exponential rise in case numbers as time proceeds. We've seen that in every country. When there's the start of an epidemic, there's an exponential increase in cases at some particular rate. What we see in Wuhan is that there's jumps, there's like steps up every time the case definitions change. And so if we weren't aware of the changing case definitions, we think infections were really growing very fast. And that is how it seemed at the end of January. It seemed like there were suddenly a lot more cases and maybe infection was really spreading very rapidly. But in fact, that wasn't the case. It was that the case definitions were getting broader and broader and picking up a greater fraction of all infections. So the black line that I've added to this slide shows what we think was most likely really happening in terms of the numbers of cases that would have met the 5th case definition, and assuming that there would have been enough laboratory testing to test every suspected case, which actually that there probably wouldn't have been in the early days. Even going back to early January, there weren't that many lab tests available. But what you can see from this black line, if you trace it backwards with this exponential growth, the blue is only picking up a small fraction of the cases that were subsequently captured by the 5th version of the case definition, allowing for mild cases and, you know, without having to have the virus sequence available, but just having PCR, which is another bottleneck for in terms of who can be confirmed as a case. And then we trace that black line backwards. It goes before early December, probably up to 100 cases in early December that met the case definition. And as I said at the very beginning, the confirmed cases are going to be a subset of all of the infections. So most likely there's more infections than even the cases that we estimate here. So this is what we think happened in the whole of China. The orange is the estimated cases that would have met the 5th case definition if the definition had been available earlier and if lab testing had been available earlier. And even going back to early December, there's quite a lot more cases. That's the inset here. And then going up to a peak with the case definition, 230,000 cases is our estimate. A lot more potential cases than were actually reported. It was only at the point in time that we did the analysis, the end of February, it was 60,000 cases. So that's almost 4 times more cases that we think occurred. And then if we think about infections, would it be even more than that? Definitely quite a lot more than 230,000 infections in mainland China by the end of February. So that's the impact of case definitions. When we look at what's happening in lots of other countries, this graphic from Financial Times is very nice. And we see, again, on a log scale on the y-axis, the exponential increases, which are straight lines on a log scale. We see the exponential increases in cases in different countries, tracking a doubling time every 3 days, perhaps, sometimes a little bit faster, but with the caveat that there's been increased recognition of spread and increased use of testing over time. So this growth rate may be faster than the real growth rate in infections, because testing is now expanding fast. And so, for example, in the US, not that much testing was being done in February. Now a lot of testing is being done. So a lot of cases are being identified now that weren't earlier. So it looks like there's rapid growth, but there may not be. And I go back again to the earlier point that cases are different to infections. It's not necessarily a good idea to look at the countries in this figure and say, you know, the US has got more infections than Spain. That may not be true. US has got more confirmed cases than Spain, but that's not the same thing. It just depends how much testing is being done. In Hong Kong, what's been happening? This is the epidemic curve for Hong Kong, and this is a classic epidemic curve. The y-axis is the date of symptom onset, and the y-axis is the number of cases. So the bigger bars mean there's more cases with onset on that day. In January and February, we didn't have a lot of cases reported over that month, but there's been a lot of cases reported in the past probably 2 weeks, particularly in people who've come back from overseas and have been identified as infected. One of the things we need to be very careful at when we look at epidemic curves is the right-hand side. Over here, on the between probably the 18th of March onwards in this epidemic curve, there's likely to be cases that are missing that are going to be added within the next few days or the next week or so and fill in that part of the epidemic curve. We can see that it looks like the epidemic curve's gone up and it's gone down again. That may not be the case. Need to be very careful with that kind of interpretation of the most recent times in the epidemic curve. This is an illustration of time lags in information, and it's a little bit more difficult to understand this kind of figure. So here on the x-axis, we've plotted cases by their date of symptom onset, and on the y-axis, this is the onset to reporting intervals. What it means is at the end of January, there were quite a lot of cases reported. Among people who had symptom onset towards the end of January, there was a long delay in the time to identify them as cases, maybe about 10 days or even up to 14 days or 15 days in some cases. So those were the cases with symptom onset around the end of January. In early February, actually the situation changed. There were only a small number of cases and they were picked up. 3 of these cases in late February were picked up after 2 days of onset, which is very, very quick. And now in March, we have a little bit changed back to before, where we have quite a number of cases that were picked up relatively later after symptom onset. And that's going to cause a difficulty for isolating them and preventing onwards transmission. One of the measures to stop transmission in the community is if we're able to identify cases and then isolate them to stop spreading. But as we heard from the previous presentation, people are likely to be most infectious around the time of symptom onset and maybe for a few days after onset. So for these cases that we're picking up 5 or 6 days after symptom onset, if they're going to spread it, most likely they've already spread it at the point that we identify them. And so we can isolate them, but we need to think of additional measures to stop transmission from going further into the community. And the way we do that is by tracing who they've been in close contact with, identifying those people that they may have already spread infection to, and placing them in quarantine. And so we isolate the people that are sick, that we know have infection, and we get their close contacts that may have already been infected, and we put them into quarantine, keep them under close observation, so that if it does turn out that they've been infected, there won't be any further onwards transmission from those people. So that's the rationale for isolation and for quarantine. And from the information shown here, it looks like isolation would be a little bit late to have a big effect on transmission, but quarantine should be able to play a role. And what we need to know to evaluate whether quarantine was working was to see how much transmission had been occurring to close contacts, and among people in quarantine, how many of them have subsequently developed symptoms. And has that been able to stop the spread of infection into the community? One other thing that I'll just note from this figure is that because of the delays from infection to symptom onset, which is called the incubation period, average 5 days, and then because of the delays in identifying cases after symptom onset, which here could be another 5 days, it means infections that occur today won't appear in the epidemic curve for 10 to 14 days. And infections that have appeared in the epidemic curve today most likely reflect people that were infected 10 to 14 days ago. And that means we need to be careful when we look at the epidemic curve in terms of judging whether policies have been effective or not. We need to wait maybe up to 2 weeks to really see the effect of changes in policies. How should an epidemic curve look eventually? So this is a really interesting one from H1N1 in 2009. And if you see at the beginning of the pandemic in Hong Kong of influenza, there's a rapid growth in cases and then a massive drop again. It looks very strange until you understand what's happening. In the early phase of the epidemic, as with other epidemics, we have exponential growth in cases. It means they double, and for influenza, it was doubling quite quickly. So doubling and then doubling and then doubling and doubling again, exponential growth. And between May and June, mid-June, all the cases that were identified were isolated in hospital to try and prevent onwards transmission, just like we're doing for coronavirus. Everyone who's sick gets isolated in hospital. That means there's a lot of hospitalizations of confirmed cases. On the 10th of June, the government announced, or the 11th of June 2009, the government announced they were going to switch policy and no longer try to stop spread, but just try to slow it down. And so from that point onwards, the cases were no longer admitted into hospital unless they really needed to be in hospital. And that's why there's this massive drop back down to low levels, because after that point, the hospital was freed up to care for people that really needed the care, not just people who were confirmed cases and were isolated. So what we see from July to September is further growth, a little bit slower actually because of some of the measures that were put in place, like the school closures, hitting a peak and then coming back down again the other side. Often epidemic curves look a little bit like bell curves, but not always, and they don't always have to look like bell curves, but they often have an exponential phase at the beginning and then a more steady rise to a peak and then down the other side. And with H1N1, what we saw as well is it never completely went away. It stayed around for a while, and then it's been coming back periodically. Even a few months ago, we were having H1N1 in Hong Kong in early January. So where are we in the epidemic stage in Hong Kong? We've heard a lot of talk about the second wave in Hong Kong. Actually, we haven't really started our first wave. We're still in the very early stages and possibly beginning to see exponential growth in local cases, but hopefully not. Hopefully, we're still avoiding sustained local transmission, which would be the start of our first wave in Hong Kong. There was a change in epidemiology in terms of where the imported cases were coming from in the end of January, early February. They're mostly from China, and then Egypt was a one source, and then in March it's been mostly Europe and the United States. So there's a change in the source of imported cases, but it's not a first wave and second wave. We're really still at the very beginning of any potential epidemic in Hong Kong, maybe at the start of the first wave, hopefully not even at the start yet. A few final comments before I come to the end. What are we trying to do to stop coronavirus from spreading in Hong Kong? We are in a containment mode, also called a suppression mode. That's the term coined by Imperial College London very recently for the UK strategy. In a containment mode, we understand that there will be infections coming into the location, coming into Hong Kong. There will be some local cases which appear, but we don't want them to spread. We do not want sustained local transmission, and containment will succeed if there's no sustained local transmission. We're okay with a small number of cases because we can't stop those, but we don't want sustained local transmission. What are the strategies to achieve containment? Two directions. First direction, use the lab testing to identify cases, isolate them so they can't transmit, and do contact tracing and quarantine so that we, even if there has been a little bit of spread from those known cases, we'll stop it at that point in the people that they've spread it to. And I think in Hong Kong, social distancing has also been a critical component of containment. So because people are staying at home more often, because schools are closed, because people work at home, because we cancel mass gatherings, that's preventing the opportunity for transmission in the community, even in people that we don't know are infected and we haven't identified as cases. The limitation of containment is that it's difficult to maintain as the numbers increase because we're relying on doing a lot of testing, doing a lot of isolation, doing a lot of contact tracing and the quarantine. And those require a lot of effort from the public health authorities. We can do it when the numbers are small. We can't do it when the numbers get too large. We can do the social distancing, but that's also difficult to maintain. If containment fails and we have to change strategy to just try and flatten the curve to slow down spread, what we'll be worried about is having an epidemic where the healthcare system is overwhelmed. That would be really bad news. And so the objective of mitigation is to spread out infections over a longer period of time so that the healthcare system can cope a little bit better than it would otherwise be able to cope. And we can help the severe infections better than we would otherwise be able to. How do we do mitigation? We can't do testing across the whole population. We can't identify every person who's infected. We'll instead advise people if they're sick, assume you have coronavirus and stay at home, unless of course you need to go to hospital if you're very sick. And then we'll use social distancing to remove the opportunities for transmission in the community. And we would like to avoid having the kind of lockdowns which are going from mitigation measures back to containment measures because they're so disruptive. So we prefer to stay in the containment mode without having to use more extreme measures that they've had to use in the US and Europe. But of course, mitigation is also difficult to sustain. How have we done so far? Fairly well. We've done a lot of testing, done a lot of isolation, and a lot of tracing and quarantine. And we've also done all this social distancing measures, school closures, working from home, cancelling mass gatherings. People are voluntarily staying at home more, improving their hygiene, and also widespread use of face masks in the community. And so far, we've kept the numbers of local infections low, although recent days there's been slight increases that we're a little bit concerned about. Almost the last thing, we've been looking at the reproductive number in Hong Kong that I think Joe will talk about a little bit later in more detail. Reproductive number is a measure of how many secondary infections are generated by people who have symptom onset here on a particular day. So I pick a day, 11th of March, a person who had symptom onset on 11th of March, we estimate that they spread on average to 0.9 other people. And we track that over time. If the reproductive number goes above 1, it means infections are going to tend to spread and increase. And if the reproductive number is below 1, then infections are going to tend to disappear over time, maybe slowly, unless the reproductive number is really, really low. And the objective of containment is to keep the reproductive number below 1. The objective of mitigation is just to reduce the reproductive number as much as possible, even if it's above 1, because that will mean that infections spread more slowly. So that's the end of my part. I can take some questions. I think we'll continue containment, and we're worried about surges in imported cases, particularly outbreaks of larger numbers of infections that would then suddenly overwhelm the capacity for isolation and quarantine.
Thank you, Professor Cowling. This is Jennifer here. I've got a question maybe you can ask. This is from Florence Dershangi from Le Monde. She is asking, what is most challenging about this virus? And is there a reason to explain why COVID-19 travels so well in comparison with previous epidemics? It seems like SARS and MERS remain more localized when they appeared.
I think there's been a lot more infections with coronavirus at early stages. So that's why we've seen more international spread than we did maybe with SARS and MERS, because the numbers of infections are so much greater. Another thing about coronavirus is that it's often milder than maybe SARS, so people can still travel with mild symptoms. I distinctly recall some of the earliest cases that traveled actually had mild symptoms. I think the first case in Thailand was a lady who had a fever and asked her doctor if it's okay to travel, and he said it's okay to travel, so she went to Thailand. So I mean, that's my answer. I think it's, with something like influenza, there's really a lot of global spread every year. We just don't watch it so carefully as we have been watching coronavirus. We haven't had everyone really paying very close attention to global spread of something like flu in the same way. Over.
Okay, and this is Keith, Professor. We've got a couple of questions here. We're going to just take one more, but I'm going to combine a couple of them because they're similar. Like Cable TV is asking, based on your estimation, how many missing cases are in Hong Kong, or can we actually guess the number of infected cases in Hong Kong and perhaps Wuhan? And a very similar question comes in that says, how many tests should be conducted per day in Hong Kong in order to really get the number of infected people effectively? Should we do mass testing like they did in Korea?
Got it. Okay, it's a lot of questions. So for the infections in Hong Kong, it's very difficult to say. Very difficult to say. I think there'll be more infections than we've identified, but maybe not a lot more. But that's a qualitative statement, not a quantitative. In Wuhan, so we estimated, hundreds of thousands of people that could have met the case definition if the case definition had been broader earlier and there'd been lab testing available. We know that some people would have had asymptomatic infection and then not even picked up by that kind of test, but not an enormously greater number. So, I mean, I'm reluctant to give an estimate of how many infections there were in Wuhan. I think we'd really like to have a serological study looking at blood samples, see how many people have got antibodies if they were infected or not. If I was planning a serological study in Wuhan myself, I'm not. If I was, I might think about how to design a study that could pick up 500,000 infections, 700,000 infections, less than 1 million infections, and make sure that I have enough people in my study that I could pick up that kind of rate of infections, which is not particularly high. And then the last question was, sorry.
Well, just how many tests do you think should be conducted in Hong Kong?
Well, I think, so at the minute we have a number of testing strategies. Firstly, like everyone with pneumonia in hospital gets tested. Secondly, everybody who goes to their doctor with symptoms consistent with coronavirus and would agree to be tested will be tested. They need to do the saliva thing. They need to take a number of steps. So I guess some people won't do that. Among the incoming travelers, we'd like to test all of those that are symptomatic, but there's been a suggestion to test all of them even without symptoms. That would really require a lot of testing beyond the current capacity. And maybe we need to increase the capacity for testing locally, although in Hong Kong, we already have probably one of the highest capacities for testing anywhere in the world, I would have thought. So, I mean, I think we're doing pretty well on testing, and it's not going to be possible to test everyone, in the future. That's not something that we're aiming for. We do testing for diagnosis, particularly for giving appropriate levels of care. And we also do testing for surveillance so we can track what's happening in the community. We don't do testing so that we can identify every single infected person as having been infected. That's not a public health activity.
Got it. And Jennifer has one question before we move on.
Yes, Professor Cowling, this is from Linda Liu from SCMP. She's saying that we're seeing maths modeling used to predict trends in the epidemic, such as what the Imperial College has done. How should we interpret findings from these modeling combined with actual numbers from testing? And how accurate are they with regards to actual infection rates, and what implications do these findings have for public health policy making?
Yeah, that's a very good question, but I think I'll defer it to Joe Wu, who's talking later about that
Modeling,
specific
okay.
issue modeling. Yeah, so I'll pass on that one. Over.
Okay, sorry about that. Yeah, we'll save that for later.
Okay. Should we move on to the next speaker?
Let me just do a quick scan to see. I don't know if you should, maybe this one from Helen Branswell. What do you think the infection fatality rate is at this point? Is that for Professor Cowling?
Yeah, I can say something, but again, Joe's published a paper on that exact question, so you should ask him as well. I mean, I think the current estimates are higher than influenza, increasing on average with age. And, I mean, that puts it in the range 0.5% to 1%, even above 1% for older adults, infection fatality rate. But I think that's one of the things that we still have a little bit of uncertainty about, because we still haven't had the kind of serological testing that could help us to identify what's the real scale of infections that have gone on. Over.
Okay, thank you. So let's move on to Professor Leo Poon. He'll be talking about diagnostics and vaccines.
Right. So can you read my slide?
Yes, perfect.
All right. Okay, good. So I'm just going to go through some of the questions that I have been asked many times in the last couple of weeks or months. right? So just try to illustrate what are the technical aspects for molecular diagnosis or clinical diagnosis of these COVID-19 patients, right? Okay, so first of all, I mean, how many different type of diagnostic tests for COVID-19? Their majority basically classified into 3. So basically detecting the virus itself or detecting the immune response from the patients, right? So you can imagine that you can only find this virus if the virus is replicating inside the body, right? And then normally we talk about after the exposure to the patient that develops symptoms and then start to recover. We have a long studying period, long windows for detecting these viruses. But then we can either detect the viral RNA itself, right? This is the nucleic acid from the viral RNA, right? So we can basically detect these, or we can detect viral protein, the protein that is presented by this virus. Okay, so we can detect the RNA by using rapid RT-PCR test, or by detecting the viral antigen by viral antigen test. Okay, right? This is basically normally used for detecting infection at the early disease onset, which I will explain it later on. Then for detecting the antibody, it would take some time after the infection. Basically, the patient would develop immune response. Normally, it takes a few days to a week. Like for IgM, we know that some of the patients will develop IgM after 5 days after the onset. But then for the IgG productions, that would take even longer period of time. We talk about maybe in the second week of disease onset, right? So you can imagine that so basically these tests are designed for detecting COVID-19 patient at different disease onset of period of time. So basically this is the time when the patient not being infected, they're still susceptible, right? After the exposure, then the patient will develop the virus, the SARS-CoV-2 will start to replicate subclinically. So basically at that time, the patient is under incubation period. The patient is not being aware of being infected, right? But then after a certain period of time, the patient will develop symptoms like now we know that fever, cough, respiratory illness, and so on and so forth. And then they will end up in maybe severe clinical outcome and end up in hospitals. And then some of them would recover, some of them unfortunately will die. And throughout this period of time, the virus, the amount of virus in the patients actually changed a lot. At the beginning, after the exposure, the virus started replicating at a low level. But then the patients start to develop symptoms that actually has the highest amount of viruses, which I will show you later on, and for about a week. And then the patients start to control the virus replications, the amount of viruses start to go down, right? And then we know that the viral RNA can be detected up to 3 weeks after the onset. Okay, so you can see that there's an upsurge of viral RNA or viruses right at the beginning and then start to subside. Okay, and for the antibody, as I told you before, so the patient will react to these infections. Normally takes 5 days to a week, and then the amount of antibody will start to go up. At the beginning, you get none, and then start to go up, and then we start to maintain that level for some period of time. So the test that I have just mentioned, based for the RT-PCR test and antigen test, they are designed for detecting at this period of time, okay? At the time that the patients start to develop symptoms because they got highest amount of viruses or viral protein, all right? So normally we will try to detect this patient at this period of time using the RT-PCR test, because this is the most well-validated test. And a lot of people, a lot of countries are using this as a method for detection. And actually, this is the WHO recommended method to detect COVID-19 patient, right? Or we can detect antigen test, detect the viral antigens, which is basically the viral protein. But the problem of this test is its sensitivity is a lot less than the RT-PCR test, right? Because in the RT-PCR test, there will be a lot of amplification of the viral RNA so that we can able to amplify the signal exponentially. But for the antigen test, you don't have similar type level of amplification. So the test is a lot sensitive a lot less sensitive than the RT-PCR test. So currently, there is no well-demonstrated evidence to show that this is a good test to identify COVID-19 patient, right? It could be used, but then the sensitivity is very low. And that means that you will generate a lot of false negative results. So there's no point in using this test to detect patient at early disease onset, because you will miss a lot of patients. And then that even worse, because of the patient, if once diagnosed as a negative, they may actually be sent back to home or sent back to the community, so that they were able to transmit the disease to another individuals, right? For the antibody test, right, basically we detect antibody reactions at the late disease onset, basically 2 weeks after the onset. And this test would not be so useful for early detection. Again, because if you use this test to detect the patients at the first week of disease onset, many of these patients actually would be negative in the test. So again, you will send back these people to home, and then you may actually let these people transmit the disease to other individuals. Now, I mean, nowadays, I mean, you may hear that there are many at-home tests. These basically are talking about these antibody tests and antigen tests. So these would not be the best test for early identification of COVID-19 patient, because a lot of false positive, negative cases will be generated from this type of test for the early onset patient. And then that actually create more problem. You're sending a lot of people back to home, and that would be a huge problem for stopping the transmission in the community. Right, okay, so now the second question that I normally ask by colleagues is, why the COVID-19 is spreading so fast and it is so difficult to control? I think some of you have already asked this question before. I just want to show you the amount of viruses that's shed by the patient from SARS patients and COVID-19 patients, right? So this is what happened in 2003. So when the SARS patient get infected, at the first few days of disease onset, like day 5, the amount of virus actually is quite low inside their body. But at day 10, so basically in the second week of disease onset, the viral load, the amount of viruses start to go up and then start to decline, right? And you can remember that for SARS patient, they get very sick at the very beginning. And then normally they will send to the hospital in the second week or first week of disease onset. Basically, at the time they have the highest viral load inside the body, they already been hospitalized. So you basically will not let them to able to transmit this virus in the community at that time, right? So that's why we were lucky at that time in the SARS time, because all the sick patients normally end up in hospital. But for the COVID-19 patient, the scenario is slightly different. And this is the time of disease onset of the patients, and this is the viral load, basically the amount of virus found in the patients, right? You can see that for the first 9 days of disease onset, the patient actually shed a lot of viruses, right, at high level, right? So they keep on shedding. At that time, in particular for early time points, these patients actually, the symptoms of this patient are quite mild, right? They're actually quite mobile. They can get to the community, they can go to the restaurant, go to the market, to shops and things like that. So that creates a lot of opportunity of these patients to shed the virus, to spread the virus to other individuals at the early time point, right? Even worse, now what we know that even we can detect a high amount of viruses right before the disease onset. Okay, so basically this we call it asymptomatic patients, right? They could shed a lot of virus without any symptoms. So that's explain why it's so difficult for these COVID-19 patients stop their transmission, because some of them are asymptomatic and they're shedding a lot of virus right at the beginning, right? Even at the time they have very mild symptoms. So, I mean, they can go to, like example, that Professor Cowling said, some of the index patients in Thailand, they were having a mild disease, and then even the cases in Egypt, Germany, they have a very mild, relatively mild illness. So they can allow to travel and spread the disease from one country to another country quite easily, right? Okay, so the other thing is the viral load, the amount of viruses of these patients start to subside right, to a low level, normally after day 10 of disease onset. At the time they get to the hospital, but it basically, the time they get to the hospital is already have quite a low viral load already. So that is another problem. And then the other issue is, now they get very low viral load after the second week of disease onset. That creates another problem, which I will explain to here. Right. The other question that I am being asked all the time is why there are some RT-PCR negative patients, right? They're recovering or they have been recovered already. Why they will become positive in subsequent RT-PCR test, right? So the RT-PCR test actually is quite sensitive. Theoretically, from a optimized assay, it can detect as little as 1 viral copy per reaction, right? So this is a highly optimized reactions, but in reality, there may be 5 copies per reaction and so on and so forth. But it doesn't matter. But the matter is why it become positive is because of the method of sampling, right? I can just give you an example. Just imagine this is an aquarium, right? You got many fishes there, and then you ask a kid blindfolded and try to use a jar to take a sample of this water. I mean, if there's a lot of fish in the aquarium, there's no problem for the kid to actually sample the fishes, right? Sometimes they have 1 fishes, sometimes they have 2 fishes, sometimes may have even 3. So the higher number it is in the aquarium, the better you can able to catch the fish, right? But then now for the case that have only 1 fish in the aquarium, now if you ask the same kid to do the same thing, and then they take the sample, again blindfolded, most of the time, basically they got no fishes at all because there's only 1 fish here. So you will imagine that if you do a number of serial tests of these patients, right, most of the time they are negative because of the amount of virus in the sample is so low. So you will only occasionally test positive if you do it continuously, right? So we call these problems, this problem is caused by Poisson distributions because the lower number of this sample in the sample, then the less chance you will able to do it, to find it. Even the test itself is very sensitive enough, but the problem, the intrinsic nature of the number of copies in the sample is low. Even a very sensitive test, you will not able to pick it up, right? So that's why sometimes when the patient start to recover, maybe in the 2nd week or 3rd week of disease onset, at the beginning they are positive about RT-PCR, then become negative, but subsequently you take another sample, it will turn positive again. But that is because the amount of viral RNA in the patients actually is quite low, right? Now, but then the other issue is whether this fish is alive or not, we don't know, right? As Professor Pierre said, there are some studies showing that after day 10 of disease onset, these viruses are actually not infectious at all. So now that we need to decide what we should able to deal with those type of patients. Right, okay, so the other advantage of using this quantitative RT-PCR assay is they can provide the copy number, basically the amount of viruses inside the body or inside the sample, right? We know that at least some limited studies should show that the amount of virus in the patient may affect the disease severity. This is one of studies which have been released very recently. So when we try to stratify the mild cases and the severe cases, what we know that is for those who are develop severe clinical outcome, maybe end up in ICU, they tend to have more viruses inside the body. This is the delta CT value. The lower it is, the more virus it is in the body. So you can see that at the first few days of disease onset, right, the severe cases got more viruses. In the 2nd week of disease onset, again, you got more viruses. In fact, what we found is some of these patients, I mean, the severe cases actually have a much longer shedding period and more virus being shed by the patients. So could it be used as a diagnostic indicator or prognostic indicator for predicting disease severity? We don't know, but we have to get additional information to support this hypothesis. Right, okay, now then I switch to vaccines, right? Many people ask us whether there's any COVID-19 vaccines. Right now, the answer is no, but there are many initiatives, right? What we know that through WHO, there are about 50 programs for COVID-19 vaccines development, right? They are using multiple different approaches. right? Some of these using kill the vaccines, basically they grow up the virus and use chemical to inactivate this virus, like formalin, to try basically kill the virus, and then use this purify the virus for vaccination, right? And then some other people use genetic modify the virus. They try to engineer the virus so that the virus lost its virulence or make it attenuated. So basically it's less fit than the wild type. And then we can use this to vaccinate individuals. Or maybe we can try to extract some of the viral component, viral protein from these viruses, and then use that as for vaccination. And then the fourth option is they try to use genetic engineering to transfer some of the genetic information from this COVID-19 into another viral vector, like MVA or adenovirus. These are vector being used for as a vaccines vector in the past. All right, so try to express this COVID-19 protein into this viral vector as a vaccines. And then the fifth and sixth options are the vaccines that use nucleic acid. They either use DNA or RNA, right? So basically, they transfer this DNA RNA into a vaccine, maybe by intramuscular vaccinations, and hoping that this DNA or RNA can express some of this viral protein from the COVID-19 and to induce immunity, right? I would emphasize that many of these are experimental ones. Only 2 of these are now under clinical trial, human clinical trial. The first one is from Moderna. So what they did is they tried to use a messenger RNA against the RNA method, which is RNA which can express a full-length spike protein of SARS coronavirus 2. Right? What they did is basically they inject this messenger RNA into the vaccine, hoping that they can express the protein to induce immunity. The second company doing the clinical trial is the CanSino Biologics from China. They are using non-replicating viral vector. They use adenovirus as a vector, which expressing the COVID-19 spike protein, right? And this vector has been extensively used in gene therapy. So there's some track record in doing that. And then now these 2 are under clinical trial. And then I understand that there are another 3 clinical trial will be launched in the next 2 months, right? One in Oxford and then one in Germany. But what I would say is, yes, these are all good, but it would take quite a while to go through this process, right? I don't want to talk about this in details, but basically, this clinical trial try to address some of these concerns. First of all, the safety concern, the potential side effect, and then also the effectiveness of these vaccines. Does it able to induce sufficient immunity to protect the vaccine against the COVID-19 infections? And then the other practical questions are the cost. Is it expensive? Is it going to be produced in a mass scale so that we can vaccinate as many as possible? Right, normally it takes a long time to do that. I mean, now just a typical clinical trial for this. You would involve phase 1, 100 people, phase 2, 100 to 300 people, phase 3, 1,000 to 3,000, right? Before we approve it for clinical for manufacture for commercial use, right? Normally it takes this process take a long time, right? And of course we are in emergent situation, but then I don't think we will compromise this. It will still take this concern. We will still take some time to go through all this process before we can able to use it in massive manner. So my answer to my colleagues is most of the time is yes, there are some experimental vaccines. Yes, there are some vaccines under clinical trial, but it's unlikely that we will have a vaccine available in near future, at least not within the next few months. I would be laughing if you have a vaccine at in early next year, right? I just want to use the 2009 pandemic as an example, right? In 2009, we have the pandemic, right? And the virus is first, the influenza virus, first detected in March, right? And then the vaccine strain was available in May, right? And then it become fully used at the end of the year, right? I'm talking about the vaccines that have been produced, influenza vaccine have been produced for many years, for decades, right? We have a very good pipeline in producing these type of vaccines all the time. And it's still when we have a pandemic, it takes a long time to go through the whole process and to make our vaccines available to public use. So now when we talk about a new emerging infectious disease, there's a lot of uncertainties. We don't know the safety aspect. We don't know the efficacy of these vaccines. So I don't think it will be likely that we will have the vaccine in a timely manner. So I do urge all of you to realize that there are other priorities. We may have to consider other non-pharmaceutical interventions to try to suppress the transmission of this virus in the community in the first place, hoping that we can able to suppress that in the level and then buy more time so that we can able to wait to the maybe next year when we have the vaccine to make it available for massive usage. Right. Okay. So this is my summary. So basically, I try to explain the RT-PCR test. It is the test it is recommended for early diagnosis for COVID-19, and there are other tests for testing COVID-19, but then they are not used for early diagnosis. All right. And then there are several vaccine development programs for COVID-19, but it will take some time before a large-scale production. So we have to wait and see. Right. So this is the end of my presentation. I'm happy to take some questions.
Yes, thank you, Professor Poon. I have one question about vaccines, also from Helen Branswell. She asked, are you worried about antibody-dependent enhancement developing from vaccines? And if yes, which types of vaccines carry the highest risk?
Right. Yes, that is something that we have to keep in our mind all the time, because in some animal vaccines, experimental one, this happened in experiment. We know that they maybe have some ADE, antibody-dependent enhancement, but we don't know whether the COVID-19 vaccine will have the similar problem or not. So that's why we have to do clinical trial to make sure that it's safe to be used before we actually launch it for massive vaccination program.
Okay. And this is Keith speaking here, and I've got a question from Caroline Carter earlier, saying that Johnson & Johnson have announced that they are developing a vaccine which could be available next year, and the US government is actually investing $1 billion. How promising is that, or can you say anything about that at all?
Well, I cannot say anything about it, but I would say that we should try to allow diversity. Right. I mean, we really don't know which one is the best strategies to try to vaccinate us. And so that's why we have now 50 programs. I appreciate that, because some of them may work, some of them won't. And then it happens all the time, like for the drugs, for antiviral development. We have gone through all these all the time. A lot of companies claiming they have a hit for particular disease. But at the end of the day, quite a lot of these R&D companies run out of business because at the end they could not survive other than clinical trial. So I would say let's wait and see. I mean, it would be nice to have some major big pharmaceutical company be involved in it because they got more resources. They have a better resources to try to run a big scale clinical trial.
Okay. Professor Poon, I've got one from Jessica Ju from Mingpao. I think it's about diagnostics. She's asking, is there a way to check whether the patient is infectious or not? Can PCT tests tell the viral load and infectious level of the patient? And is RT-PCR a good tool to decide which patient is less infectious, so as to decide which patient to put in the tier 2 isolation facilities here in Hong Kong?
Right. So now I would say none of these tests can reflect the infectivities of these samples, right? Because we are testing nucleic acid, RNA, viral protein, or the antibodies. So it does not immediately translate to the potential infectious potential of this clinical specimen. But I would say that if you have a high amount of viral RNA or high amount of viral protein, you may have a higher chance to get an infectious virus. So having this RT-PCR assay, I mean quantitatively, will help us to inform which patients will be potentially more infectious than the other, right? And then for the other pure PCT tests, I don't think they're testing the the viral RNA. So they would not able to tell you whether they're infectious or not. They just give you the result whether you have been infected or you're positive or not. So it doesn't reflect the amount of virus inside the body.
Okay, and we've got a lot of questions coming in. We'll save some for later, but I do have one from Nicole from the FT. She's asking a question for Professor Poon. Some countries are adopting an immunity test system. Do you think that's a good way to control the spread and allow people to get back to work?
Well, I mean, immunity testing system basically can tell you whether you're seroconverted or not. So basically, whether you have been infected 10 days or 2 weeks ago. So, and in that case, you really cannot tell. I mean, stop the transmissions. So I don't think that would be good. I mean, it would be good. I mean, to do these tests to inform us how bad is the situation in the countries, like how many percentage of these patient population have been infected by COVID-19 or not, right? So this will be informing for policy making. But then in terms of the stopping the transmission real time, I don't think that will be the right test for that.
Okay.
Okay. We're getting questions, but a lot of them are actually not specific for Professor Poon at the moment. So how about we move on to the next presentation from Professor Wolf on mathematical modeling, and we can leave more time at the end for all the questions for the various speakers. Professor Wolf, over to you.
Hi. Let me start my video. Okay. So is the screen showing my slides?
Not yet.
And
Jennifer, you're doing that, right? You're loading the
Oh,
slide.
no, Professor Wu, I've given you access, but I can do it for you. No
Okay,
problem.
let me try from my end. I thought
Okay.
we were going to do it. Okay, hold on. So share screen. Is this
Perfect.
working?
Yes, yes. Great, perfect.
Okay, so for the next 15 minutes, I'm going to talk about basics of infectious disease modeling. So first, before we talk about infectious diseases, let's talk about what we mean by models. So conceptually, it's very simple. Models are basically our understanding of how things work in the real world. And all of us use models to make decisions every day. For example, say when you buy a house, you take into consideration, for example, your income, what kind of house you like, your needs, and also, for example, the prices of similar apartments around the area that you're interested in, so on and so forth, in order to select what you think is the optimal apartment for you. And that's going to be different. The models that you use for yourself is likely to be different for different people, depending on your needs, your purchasing power, your locations of preference, etc. So although we use models on a daily basis to, in our daily living, many of us are not aware of such use and actually couldn't articulate the kind of models that we use when making those decisions. So mathematical modeling is basically a process, to articulate the assumptions and the data that you use when you build these models, whether inside your head or on a piece of paper or in a computer. So the reason that we use models for are then basically the corollary of what I just said, for understanding and predicting phenomena in the real world. And in the context of infectious diseases, of course, epidemics is the phenomenon that we are interested in. So having said that, models aren't necessarily approximations or simplifications of real-world systems. These models have to be complex enough in order to provide robust answers, meaning it has to have the essential realistic components in order to be helpful. But at the same time, it has to be simple enough to avoid unnecessary details. So for example, when you are trying to purchase a house in Hong Kong, you probably don't need to, know what the housing prices are in different parts of Africa. So Albert Einstein said it quite nicely in a very succinct way. He said everything should be made as simple as possible, but not simpler. So in this field, infectious disease modeling, that's exactly what we're trying to do. Building models, not for the sake of, doing the math or showing pretty simulations, but to help us understand epidemics and also help us to predict what's going to happen under different scenarios. What I just said is very nicely summarized by this recent book chapter by our long-term collaborator at Harvard, Professor Mark Lipsitch. So you can look at, I strongly recommend reading this paper, which was published last year. So you can find it here. This is the title, this is the book. So here you see 4 layers. At the bottom are basically my job, which is to build the analytics, to build the models for interpreting the different data stream regarding the epidemic process. So the kind of inputs that we have, the data, encompass different data streams, including, for example, for places where there's sufficiently good surveillance system, confirm the case count. So these are typically confirmed using laboratory tests such as RT-PCR. In more resource-strained setting, surveillance may be based on just symptoms, in which case we're looking at syndromic surveillance. At the beginning of outbreaks, especially for emerging infectious diseases like COVID-19, there's typically a short period of very intensive time for doing outbreak investigations, where the epidemiologists, the field epidemiologists, will be collecting a lot of data regarding, for example, the different demographics of the cases and the context and the transmission settings. Malik and Leo has mentioned something very important that is, and Ben also have mentioned something very important that is currently missing, not done yet, which is the serological data. So for those people that have been infected in a lot of infectious diseases, exposure to these pathogens could be inferred by looking at the presence or the concentration of antibodies in their bloodstream. So in the absence of vaccination, exposure, infective exposure, would be the only explanation for an increase in antibody responses. So that would be a very good biomarker for estimating the true number of infections in the community, in which case that estimate will greatly help us to characterize the severity of the disease. And also, for example, virus surveillance, this will be very important for pathogens that can mutate over time very quickly, for example, influenza. But as Malik has mentioned, this is probably not so important at the moment for the SARS coronavirus 2, which is the pathogen causing COVID-19, because the mutation rate is relatively slow. So the way that the reason for trying to integrate, trying to analyze these data collectively is to provide the evidence, okay, for making the decisions, which is at the very top. So if you are the decision maker, these are the questions that you'll be asking, or these are the questions that people will ask you. First and foremost, the overall scale of response. I mean, for example, going back in time, say 2 months ago in January, when the outbreak was still mostly happening in Wuhan, the burning questions at that time at the WHO and many scientists all over the world is that, is this going to spread to other parts of China and then later on to other parts of the world? So basically asking about the transmissibility, okay, of the pathogen. So that's why the transmissibility of a pathogen, typically characterized using the basic reproductive number, is almost always the first epidemiological parameter that we try to estimate, because that tells us whether this thing is going to spread and how widespread it might be within the short future. You'll also be asked, for example, how many people are going to die if this becomes a large-scale epidemic. So for that, you need to characterize the severity of the disease. By severity, we typically mean case fatality risk, but then this term is quite loosely used in many contexts, both in the scientific literature and also in, for example, many newspaper or blogs, when the case definition has not been really defined the same across all these appearances. So for example, in our recent paper published in Nature Medicine, we estimate a symptomatic case fatality risk, which means it's a ratio. In the numerator, we have the number of deaths, and in the denominator, we have the number of symptomatic infections. So not all infections, but only those infections that show symptoms. And in other contexts, for example, at the beginning of January and actually in February, the WHO was quoting a case fatality risk in Wuhan, for example, of 3 to 4%. In that context, by cases, they meant confirmed cases in Wuhan. So as Ben mentioned earlier, what people mean by case may be very different. So in our Nature Medicine paper, what we mean by case is actually those infections that are symptomatic but not necessarily confirmed. Whereas in the WHO headlines, what they meant by case was confirmed cases, which is just a proportion of all symptomatic cases. So that's why you see the differences in those numbers, not necessarily because the estimate has been substantially revised below or someone has done some miscalculation, but sometimes it's just because the denominator are not the same. So you need to be careful when you interpret these measures. So coming back to the questions, overall scale of response, these two things, transmissibility and severity, are the two most important parameters that need to be characterized in almost any epidemics or pandemic. So questions that decision makers are interested in is when you have countermeasures, should you target at certain group? For example, if you know the transmission engine, the demographic group, which demographic groups drive transmission, you might try to reduce the social mixing in this group in order to reduce the overall transmission in the population. So for flu, for example, we know that school children is one of the core engine, and that's why in Hong Kong, for example, we close school when the flu activity has hit a certain critical level. But for COVID-19, there still is a large uncertainty on whether school children, first, are they equally as susceptible to infection? And second, are they equally susceptible to disease if infected? So at the moment, there are some conflicting evidence. I haven't seen any good published evidence yet. Many of these evidence are still in the preprint phase, which means they have not been peer-reviewed yet. So knowing that will help us to inform the decision. For example, how long should we keep school closed? Because this is as you know, is a very disruptive policy for a lot of people in the society. So anyway, I think you get a picture. Basically, these are the data, and in order to sort of like collectively make sense of this data, we need tools. And this is what we do in infectious disease modeling. This is the famous schematic by Professor Ferguson at Imperial back in 2003 when he was working on influenza pandemic at that time. So at that time, the world was worried about something like H5 becoming human-to-human transmissible. Nonetheless, the same sort of like epidemic theory would apply to COVID-19 that we are seeing. So basically, according to this schematic, you can dissect the epidemic curve into different phases. The first being the establishment phase. This refers to the time when the pathogen is first introduced into the human population, and is trying to establish its presence by not getting extincted, in the sense that typically when new pathogens are introduced into a population, the number of cases are small. And when the number of cases are small, there's a lot of what we call stochasticity, which means random effects. So even for a pathogen that can potentially cause exponential growth, the number of cases may actually hit 0 just by chance. It's kind of like if you flip a coin, if you flip long enough, you'll get a string of 10 heads, not because you are particularly lucky or unlucky. It's just a matter of chance. Once the number of infections have grown large enough, then the epidemic will enter the so-called exponential growth phase, which is, I think, what we're seeing in many parts of the world. It grows exponentially because this is an infectious disease, and typically during this phase, especially for a pandemic pathogen, there's no pre-existing immunity. So there's a lot of susceptibles that could be infected, which means for the first few generations, each generation of infections basically see the same kind of transmission settings. So susceptible is not a limiting factor for transmission, and that's why you see exponential growth. In the first generation, on average, each person may infect 2 new cases, and these 2 new cases will go on to infect the same number of average number of cases, for example, 2. And it goes on until the level of susceptible has hit a threshold, and that threshold is what we call the reproductive number being 1. So that means the number of new infections generated by an infection at this time is exactly 1. It's just enough to maintain the prevalence of the disease in the community. And once the epidemic has passed at that point, the epidemic prevalence will go down because they are not enough susceptible to keep the epidemic from growing. So, and then after the epidemic has mostly subsided, it will either just disappear if the replenishment of susceptible is not fast enough, or it will enter the so-called endemic phase, when the replenishment of susceptibles equals the infection rates. So whether there's enough replenishment would depend on, for example, the strength and the duration of protective immunity for people who have recovered from previous infections. At this moment, I think we still don't know. And that's why, as mentioned earlier, serology will be very important in the next few weeks or months. So this is why the basic reproductive number is so important, because it gives an indication on whether the epidemic will die out without exponential growth, or will likely result in an exponentially growing epidemic. So this is a schematic, this is not data. It's just showing you that if R0 is less than 1, for example, you see 10 cases in the population, this is the likely trajectory. So each generation, the number of new cases will decline according to this basic reproductive number. And then it will not disappear completely. It will take several generations, because each infected case on average can still infect this many number of infections. Versus this case, when R0 is greater than 1, then if you see 10 infected cases, 10 infected cases at time 0, if R0 is substantially above 1, say 1.5, there are very few, the chance that all these 10 infected seeds will just die out without causing a self-sustaining chain of transmission is very small. So as long as a few of these seeds are successful in generating a self-sustaining chain of transmission, then you will see exponential growth. And the way we estimate R0 there are typically 2 cases. First is very intensive contact tracing and cohort follow-up. So this might work at the very beginning of an epidemic, and if you can identify all the contacts, and if cases are not so difficult to find. For example, for SARS, SARS cases are readily identifiable because almost all cases will show obvious symptoms. This is not the case for COVID-19 because, as you have read in the scientific literature or in the news headlines, there are substantial proportion of asymptomatic infections, which means these cases are infected, but over the course of the infection, they actually don't know that they are infected. You will only be able to tell that they are infected if you swab them and test them using PCR. So these infected people are difficult to identify, and therefore the chain of transmission that they cause will be difficult to map out. So the first approach probably won't work for COVID-19. So the alternative is to build models to fit the model to epidemic data. By fitting model to epidemic data, we mean we run the model. So we try different parameters, we try different values of R0, and then we look at which R0 will result in a model output that best agree with the epi data. One of the major principles in infectious disease epidemiology is this concept of herd immunity. So in case you're not familiar with this, let me just spend a minute to talk about, sort of illustrate how it works. So the idea is that immunity of an individual not only protects the individual himself from infection, but also reduces the risk of infection for everyone in the population. So not just the close contact, but everybody in the population. But of course, this indirect protection would be stronger for close contacts. So here's the schematic. Suppose this is the population. So each bubble corresponds to a person. Blue people are completely susceptible, just like now. Most of us are susceptible to COVID-19. Red people correspond to those who are infected, and green people, not shown here yet, are those that are vaccinated or immune. So suppose vaccinated people are completely protected, okay? And suppose on the left-hand side here, this is the epidemic trajectory if we do nothing, okay? So this is the first introduction, and then this primary case will infect these two secondary cases, and so on and so forth. Now, suppose you have the option of doing vaccination, okay? And suppose you vaccinate these people. And let's see how this vaccination changes the epidemic trajectory. So basically you map out, okay? You follow the same paths as in the original destiny of the epidemic, but then you stop, okay? When the transmission cannot continue when you hit a vaccinated person, because by assumption, they are completely protected. So by comparing this alternative destiny of the epidemic under vaccination to the original destiny of the epidemic, you can then identify those who are indirectly protected, obviously indirectly protected because of this vaccinated people. And these are the orange people here. So for example, this person would have been infected in the original epidemic destiny, but is now protected because this person is vaccinated and completely protected, okay? So this is what we mean by herd immunity, that vaccinating these green people not only protect themselves, but also protect these orange people. A corollary of this herd immunity concept is that we don't need to vaccinate the entire population in order to prevent or stop a growing epidemic. And the reason is that it's easiest to illustrate using this simple mathematical model. So suppose in the absence of vaccination, the reproductive numbers are not. Suppose you have the option of vaccinating randomly a p proportion of the population, okay? So which means that for every context that a new case C, okay, there's a chance P that this person, this contact is protected and therefore transmission cannot occur. Now the question is, how large would P have to be in order to prevent an epidemic? And going back to the definition of the reproductive number, if the reproductive number after vaccination is lower than 1, then you'll be able to prevent the epidemic. Which means that, based on the previous slide, because the post-vaccination reproductive number R is equal to 1 minus P times R naught. P is the vaccination coverage. And you want to prevent the epidemic, which means you want this R to be smaller than 1. Okay? If you rearrange this inequality, then you will find that, well, P must be larger than 1 minus 1 divided by R naught. So for example, if R naught is 2, which is one of the best estimate for COVID-19, then you need to vaccinate at least 50% of the population. This is a very simple model. It doesn't take into account age structure. It doesn't take into account age-specific susceptibility, etc. But it illustrates the concept that we don't need to vaccinate everybody in the entire population in order to prevent transmission. And also that by knowing this very simple, this very crucial transmissibility measure, basic reproductive number, we're able to at least get a ballpark figure on what level of herd immunity do we need in order to stop transmission from happening. So this is a figure illustrating the function of this so-called critical coverage on the right-hand side, 1 minus 1 divided by R naught as a function of R naught. So as R naught increases beyond 1, it rises very steeply, okay, and then asymptotically plateauing towards 1. And this is also why a precise estimate of R naught is quite important. So if we are for COVID-19, we are in this region, and as you can see, the curve is concave, which means if you move to the left or right a little bit, it makes quite a big difference to the critical vaccine coverage that you need. So that's why we want to get the best available data to get the best available estimates of R naught, because it matters in terms of how we devise or advise policies. The simplest epidemic model is the so-called SIR model. It's called SIR because we make the assumption that we're looking at a closed population, and we partition the population into 3 compartments depending on whether people are susceptible, infectious, and recovered. That's why it's called SIR. I'm not going to talk about the details, but in this very simple model, we make a lot of very, very simple assumptions just as a start. So for example, we assume everybody is equally susceptible to infection, equally infectious. Mixing behavior is basically mass action, which means the risk of infection from the risk of acquiring the infection from anyone is the same for anyone in the population. So even with this very simple model, we can replicate the kind of epidemic curve that you expect to see for an acute epidemic, as I've shown in the picture by Professor Ferguson, the anatomy of an epidemic. So basically 2 hallmark features. First is the exponential growth phase, and second is the peak, okay? And at the peak, the reproductive number is 1. Even though this is very simple, you can very quickly increase the complexity or the realism of this model by adding more crucial, necessary complexity into this model. For example, age structure, which we know is very important for COVID-19, and also geographical heterogeneity. So for example, when we try to estimate how fast the epidemic is spreading from the epicenter to other parts of China or other parts of the world, we need to stratify the population in consideration by their geographical location. But this is sort of the basic, okay? We start with this, almost always start with this, and then we add complexity 1 piece at a time, depending on necessity and depending on data. And basically, those are the basic tools that we used in the modeling papers that were published so far. So the first one was the paper in Lancet, trying to project what the epidemic would look like in Wuhan and also subsequently other parts of China, if there were no intervention, if there were some interventions, etc. And the more recent one on the clinical severity of COVID-19 based on the transmission dynamics in Wuhan. That's the end of my presentation. Thank you for listening.
Great. Thank you very much, Dr. Wu. We had a couple of earlier questions on modeling. I'll just go back and find one or two of those. There was one here earlier. I'm just finding, yeah, from Linda Liu, who asked about modeling, since we're talking about that, saying we're seeing all kinds of math modeling used to predict the trends in the epidemic, such as what the Imperial College of London has done. And she asked, how should we interpret these findings from the modeling combined with the actual numbers from the testing? How accurate have these models been with the actual infection rate? And what implications do these findings have for healthcare policy making? So in other words, how do healthcare policymakers combine these models with the actual numbers they're getting from the testing?
Professor Wu, before you answer that, can you stop the sharing so we can see you on the full screen? Thank you.
How do I do that?
Yeah, just press
at the bottom.
Sharing on the bottom of Zoom. No, go back into Zoom and then go to stop sharing. There should be a bar.
So I'm looking at Zoom.
It's okay. Go ahead. I'll get someone. Oh, yeah, that's it. Perfect.
Okay. Did you need that question again?
Yeah. So the question was that there were all these model predictions from different world leading groups, and how should we assess them? I guess.
It was basically saying we're seeing mathematical models used to predict these trends, such as from Imperial College of London specifically. How should we interpret these findings from the models combined with the actual numbers that we're seeing from the testing? And how accurate are these models compared to the infection rates that we're seeing? And how do healthcare policymakers balance? How do you balance off these models versus the actual numbers that we're seeing?
So first, going back to the purpose for using these models. So first is to understand what's going on, which is what we now call nowcast. You know, you look at all the available data, epi data and clinical data, and you try to build a coherent story. What all these data are telling you, accounting for all kinds of biases, including limited testing, including increasing capacity of testing over time. So the epi curve that comes from the testing, confirmed cases, is almost always a distorted picture of what the underlying epidemic curve looks like, because you can imagine that it's influenced by not just testing capacity over time, but also the reporting behavior of sick people and health, wary people. Whereas in the model, we always try to characterize the underlying epidemic dynamics. Okay, so at least for myself, those predictions. So once we have a model, of course, people will ask, using a model, what would your predictions be for the next week or next month in terms of the number of cases, in terms of the number of deaths? I typically shy away from giving a number because the future, just by the same token, will be heavily influenced by how people behave, how people reduce their mixing, how people seek care in the future, how testing capacity will be changing. And those are not what the model can do. Okay, models cannot predict how humans behave, at least not the kind of models that I use and I read about. Instead, I think, for example, what the Imperial College team has been doing is more like projections. Okay, so they have models that they think is a pretty good description of the underlying epidemics, and they prescribe different scenarios. say we do school closure for this long, or we do general social distancing for this long, what's going to happen? Likely. They are not saying that, you know, this social distancing will happen or school will be closed in the next few months, but instead, these are just thought experiments. And these thought experiments are going back to the first slide that I showed, the market schematic. They provide these scenarios to try to inform policies. Okay, so basically laying out on the table, saying these are the options. Okay, these are the strategies. These are the likely outcomes associated with these different strategies. So what's the best way to go forward? And those models are not just, it's just, I think, one of the inputs for making policies, because we are talking about a very large scale epidemic. Even if the governments go forward with a certain policy, it will really depend on the general compliance, the willing compliance of the society to make that happen. Okay, how compliant the population will be, I mean, who knows? So I wouldn't try to sort of compare the numerical quote unquote predictions, you know, predicted number of deaths, whatever, from these publications to the actual numbers that we see in terms of confirmed case counts or confirmed deaths, because I don't think those predictions were made for that purposes. Over. Okay, sorry.
Keith is on mute, sorry.
Yeah, I think we probably want to move on to Professor Kajimoto's presentation, then we could save some of the questions at the end. How's that? Okay, Masato, are you ready to go?
Sure, all right. Let me see how I can.
We like your avatar, by the way.
All right, share and play. So do you see my screen now?
Perfect.
Okay, all right. I really feel like I'm the odd one out here, but I think one of the reasons why I was invited to talk at this panel is this on the screen. Experts like academics and also working journalists, we tend to dismiss nonsense information that we see quite often and simply ignores it because, you know, it's hard to believe. I mean, who's going to believe that? Without actually realizing how many people in the news audience actually believe those stories and share those stories and actually sometimes act on those information. One very simple example. Here's a statement: warm water can kill coronavirus. It probably sounds silly to people who are trained in medicine or even basic science. But in Canada, this claim was spreading quite widely. And the claim here is that Department of Health in Canada is telling people to drink more water regularly, and those water should be warm. Same rumor is in the Philippines, attributing to the authority there. Taiwan, the same story. In Japan, people are saying that people in Hong Kong are drinking warm water, therefore they're preventing from getting coronavirus, and we should do the same. Now, Brazil, Indonesia, Spain. In Spain, rumors are saying that Canadian government recommended people to drink water. Cambodia, it was the UNICEF who's recommending this. Venezuela, and lastly, I think India. So even though this nonsense statement, warm water could kill coronavirus, can be something that people actually share in many of these countries. And this is the reason why I think I'm here, because one of the topics that we're going to be discussing today is the public health communication, right? So for journalists, I want to talk about two issues in the next 10 minutes. The first one, how to identify or how to rethink what is newsworthy when it comes to internet rumors, and media's role or news organizations' role in misinformation ecosystem. And I only have 10 minutes, and I don't think I can actually go through the tools and techniques that I use in my fact-checking project. So I will just share some of the resources that you can look up after today's workshop if you're interested in fact-checking. So there are lots of social media platforms and messaging apps that people use to communicate with each other and share information. And for each and every platform, there is slightly different strategy and tools that you can use. And again, I can't really go into the details, but if you're interested, you can email me after today's workshop, and then maybe we can discuss the details. One tool I can recommend is called CrowdTangle. And if your newsroom has an access to CrowdTangle, I would highly recommend you to learn how to set up your own lists. With CrowdTangle, you can at least monitor Facebook groups that you like, Facebook pages, and also Reddit threads and Instagram. And it's quite robust tool. If your newsroom doesn't have an access to CrowdTangle, they have a public display page as well, and URL is on the screen. You can screen capture this, or I can send you the link if you're interested. This is probably another place you can start sort of looking at what sort of things your audience is actually talking about and sharing. What is trending on Facebook? What is trending on Instagram right now? Even though that information is not really something that you would think newsworthy normally, if many people are actually acting on that particular information, you should probably rethink what makes news, especially with the current situation with COVID-19. I have my own fact-checking project called AniLab. We do try to debunk some of the rumors on a daily basis. It's really hard with the students, but we try. We are part of the International Fact-Checking Network. We have a global alliance against COVID-19 misinformation. Together, we have so far, in the last 2 months or so, published 1,500 articles from 60 plus countries in 15 languages. And if you visit Pointer's website, we have front-end database where you can search particular information. And I'm telling you this because if you're interested in fact-checking, the first thing you do is to see whether other journalists have already investigated that particular claim and see if it's been verified or it's been debunked. So database, or I mean searching for fact-checking stories is the first step. Every fact-checker does. Currently, we are talking, well, we meaning International Fact-Checking Network. IFCN is in talks with Google, and Google is taking our database and including it in part of the algorithms. So our stories will be part of the organic search results as well. So you don't even have to go to Pointer's website to search for our stories. It appears high, it surfaces higher in organic search results as well. So there is a benefit for news organizations as well. You will get more visibility if you join this kind of global alliance. We are also working with Twitter, and Twitter is another tool that journalists quite often use to gather information, and it's quite useful for finding what we call potentially problematic content. We do have a Twitter list. If you subscribe to this, all the members in the alliance publish their story through their Twitter account, certified Twitter account, and it will be part of this list. So you will see it being updated every day. And if you are interested in this, again, setting up monitoring system is quite complicated, but Twitter is a good place to start. And there are lots of lists already available that you can subscribe to. So you don't really have to set up your list on your own. There are many out there that you can simply subscribe and see what sort of things fact checkers are monitoring. In my observation, there are 5 types of misinformation about COVID-19. And these are the 5s, and I don't think I need to repeat these. Many of you have seen this. You know, origin is the conspiracy theories. You know, where did it start? Is it Wuhan? Is it America? Is it Italy? There are lots of unfounded claims regarding this. And certain patients develop these symptoms, but others don't. So symptoms, miracle cures, governmental reactions, governments hiding something. There are so many, lots of stories like that appearing on every day in our monitoring. And I'm showing these types because this goes to the second point of my presentation, news media's responsibility. Now, if you look at these 5 types, you might probably wonder, well, some of the stories I have written or I have broadcasted before actually falls into one of these 5 categories. I think sometimes we are also responsible for amplifying fears among the public and also amplifying misleading claims. Here's one example I saw the other day, and I don't want to point fingers, so I don't name the news organization, but this is a fact-based news reporting. It's even fact-checking. If you look at it, health experts say drinking water every 15 minutes does not prevent coronavirus infection. And yet the picture you see there is an expert from WHO drinking water. And there's in the backdrop, you see a big sign which says COVID-19. This is not really a good way to communicate your news story with the public. If you think about how people consume new media content, they look at the picture first, and they look at the headline. And 1 hour later, they don't remember the details. So many people look at this and remember WHO expert drinking water, and the news story was about something about drinking water preventing COVID-19. And if you think about, at least in Hong Kong, if you're sick and if you go to see a doctor, almost all the time, your doctor would say, drink more water, drink more water. So I think that kind of messaging has been repeatedly done over the years, at least in Hong Kong, in my experience. And if they see this kind of news report, they will make that association automatically, right? So having in the headline does not prevent is not probably good enough. So the way you present news is something that we should probably be discussing and reconsidering, as an industry as a whole, when it comes to this kind of public pandemic crisis. Another good example in Hong Kong is the toilet paper run. It started as a rumor saying that factories in China is being closed. There will be no more toilet paper import into Hong Kong. Therefore, we have to buy now. It was a misinformation initially, but soon after people started going to supermarkets, started to queuing up to buy essential goods, including toilet papers, I've seen so many news reporters going to nearby supermarket, taking photos and videos of people lining up, empty shelves. And I think that actually created the real shortage because logistically, supermarket chains couldn't cope with that much huge increase in demand. So this particular case, I think the rumor has become self-fulfilling prophecy. In other words, it became true. Thanks due to, partly at least, in my opinion, news media's coverage, very exciting coverage. This shelf is empty, this line is, I don't know, 100 meters long. So I think that kind of coverage would not help the public at all. And here on the screen, I captured one tweet from a journalist from Bloomberg, I think. And she's in Tokyo, I believe. And she says, tweeting everything you see is not journalism, and I quite agree. And it's something that we should be thinking about when we think about public health communication, because news media is a big part of this information ecosystem. Speaking of information ecosystem, when we talk about so-called fake news or misinformation or disinformation, we normally think about false information, outright fake, falsehood, non-factual piece of information or claim. And that's not really the case. If you think about all the media you consume every day, all the information you get from, I don't know, TVs, newspapers, radios, or through social media from your friends, there are actually lots of cherry-picked facts. They're all basically facts, but still misleading, or very biased commentaries based on facts, but opinions very biased, and you get misled by that. So, or raw information, simply nobody can tell if it's true or not. It's just happened right now, right? Doctors are still uncertain. That kind of raw information or fact-based misleading information is much bigger circle. And this is something that we should be aware of as somebody who's working for news organizations, because sometimes your news report is also part of this misinformation ecosystem. Now, people actually, from the demand side, news audience side, they don't care what is disinformation and what is raw information. They just share whatever they see is helpful for their friends and families, maybe. For us, we have to sort of address this. We have to, I would say, keep reminding ourselves that fact-based news reports can be also misleading too. And I think toilet paper run is a good example. That headline and the picture I show is probably another example of that. Now, 2 or 3 more minutes, I guess. There are lots of resources available already online. If you go to Journalists Resource website, this is managed by Harvard University Shorenstein Center. They have lots of summaries of academic research specifically for journalists. There is a lesson on statistics for journalists. And in this particular case, I found this article quite helpful to think about how to report panic buying as a responsible journalist. So I highly recommend you to check out Journalist Resource on Harvard. I already mentioned Pointer and IFCN's effort to form a global alliance against misinformation. They actually have a daily newsletter. So if you subscribe, you can get a daily sort of dosage of fact-checking stories and also tips and the latest development in medical industry, something like that. So something that you can think about. In Asia, Health Analytics website, this was led by Data Leads in India. They have fact-checking stories and also lots of data, specifically more focusing on Asia. So it might be a useful resource for you. GIJN also has this article, and I find it extremely helpful because this article has lots of links to other external resources that journalists can use. So you can search for this article. If you ask me to name just one resource that journalists can go to right now, is the First Draft News. Their website is very robust. They have lots of research done on misinformation already. They have lots of training materials, and they have many webinars upcoming next month. So you can actually get to talk to those journalists who have been thinking about what are the ethical responsibilities for reporting pandemics like this one, or they have like, you know, quick and dirty tips and tricks that journalists can use. So it's quite handy. It comes with lots of tip sheets like this one. I mean, I don't think I have time to read through this, but if you're interested again, you can check out First Draft's website. And here's my last slide. Since I'm sharing the panel with medical experts, I just want to illustrate how difficult it is for journalists to report this kind of topic. And this is another very simple example, like warm water. Air conditioner, should I turn it on or turn it off? Right? In Singapore, authority says that there's no evidence COVID-19 can spread through aircon systems, so don't worry, use it. In India, local government actually bans it. It's very dangerous, don't use it, right? You are prohibited from using air conditioning system. Another expert in India says, no, that's not true. Home aircon's fine, but bigger buildings, central air conditioning, that's the problem. So we should be careful about that. It's very confusing, mixed messages. In Australia, if you are in public transportations like taxis and other vehicles, using air conditioning is encouraged, right? Use it. Whereas in Cebu, Philippines, it's prohibited. Public buses and public transportations do not use air conditioning system because they're afraid that virus will spread. In UK, the same thing. Now, if you look at CDC in the US, they're actually recommending, right? please to have good airflow, use air conditioning system. And back locally in Hong Kong, as CHP also says the same thing, right? Ensure that air conditioning system is functioning. So even a simple thing like, should I turn on or turn off aircon is something that people probably are asking themselves through, their daily communications. And yet journalists cannot really provide the real answer. And this kind of uncertainty creates anxiety, and that leads to, panic buying or believing that drinking sanitizer is going to help them. So people act on this kind of information. And again, I'm just showing this because I think it's really difficult for news reporters to understand, right? This kind of, well, I think I made my point. I'll stop here, and that's it.
Okay, thank you very much for that, Masato. And you can stop sharing your screen now so we could see everybody's face back in again. Yeah, down at the bottom, you could just say stop share. And we are going to, perfect. Perfect, thanks very much. And we are going to move into some question phase. I'll ask the first few questions here. I'm going to try to, we've got a limited bit of time. We will go over just a little bit of time to make up for the technical problems we had. And I'll try to be as concise as possible. And when possible, just maybe see which of our panelists can address which question if we want to do it that way. Okay, are we ready? Okay, let me just ask the first question. This was actually waiting around for a while from Florence, who was asking what accounts, and I guess Malik, Dr. Paris, I could ask you just maybe to start on this one. It says, what accounts for the very low number of deceased patients in Hong Kong? Even though the numbers of infected have been going up, the number of deaths is actually relatively low. And may I add on my own question at the end of that is, why do we see, for example, Germany has a huge number of cases, but very low number of deaths? Is that just the way that the patients are treated, or what accounts for that?
I think Ben touched on this. You see, I mean, say, for example, number of deaths is a hard outcome measure, right? But that is, but when you compare the number of deaths to the number of cases, the number of cases that are reported is very variable. I mean, that depends on, as he pointed out, how intensively you do testing, who is included in testing. So a whole number of things. So the denominator is extremely variable. And this, I think, is one of the most important reasons for these varying case fatality rates. But of course, I mean, there could be also, management issues, treatment issues. But I think by and large, much of the variability that we see now is really the denominator being not the same. But maybe Ben can expand on, Ben or Joe probably could expand on that.
Sure. Who else can expand there? Ben or Joe? You want to talk about
this? I totally agree with Malik. I think there's more of an issue with the denominator than the numerator, but there is also an issue with the numerator where delays in the time to death, for example, delay of 3 weeks on average, will make it seem like at an early stage in the epidemic, there's not going to be so many deaths. But if you wait another 2 or 3 weeks, then that's when the deaths really start to increase. And I think that's what we're going to see in New York and some other places in Europe that are really having a lot of infections and cases now, but haven't yet seen a surge in deaths that's on the way, unfortunately. Over.
Okay, can I keep you on there just for a minute, Ben? And please, anybody else jump in. Because I get this question by email from a friend who lives in Italy, from Italy. She's asking the question: is Italy just an outlier because they seem to have so many? The percentage of deaths versus the percentage of infections is so much higher than any place else. And considering this population size of Italy, or do we think others are on the way to becoming another Italy?
Right, I think Italy was affected earlier, and they seem to have a lot of infections at an earlier point in time than other parts of Europe, and perhaps there was some kind of occurrence in Italy of maybe a super spreading event where some of the earliest infections spread to a lot of other people, and that gave the epidemic a kickstart or a head start in Italy compared to elsewhere. So right now, Italy's at a more advanced stage of their epidemic, and that's why there may have been more deaths observed now. But I think if you wait for another 3 or 4 weeks, actually the death rate would be quite similar in Spain and France and the United Kingdom and New York in terms of the rate of deaths divided by confirmed cases. It's just that Italy's been affected earlier and then taken the epidemic control measures a little bit earlier as well.
Okay, great. Thank you for that. And that other question was directed again to Dr. Paris, but again, anybody can answer that. He said, could you talk a bit about your view on the effectiveness of hydrochloroquine, which is being promoted by a lot of people as a possible cure for this?
Right. So there is evidence in the test tube, right, that hydroxychloroquine does block virus transmission, and it's effective against quite a broad range of viruses. There's also some evidence from animal studies in other coronaviruses. I mean, not specifically this one so far, because there has been no good animal model for this virus until right now. I mean, things are appearing. So that is at the test tube and the animal model level, that's where we are. Now, of course, there have been some clinical trials. I mean, particularly there was a trial reported from France. And this, I think, really illustrates why it is very important to look very carefully at these clinical trial data. So first and foremost, I mean, that study from France seemed to be extremely impressive. First and foremost, of course, they were reporting not on clinical outcome, because all those patients were very mild and all of them survived, whether they were treated or not, but they were looking at the effect on the viral load, it coming down faster. Okay, I mean, that's still something. But then if you look very carefully at the design of the trial, you find that most of the cases who were treated came from one hospital, the controls came from another hospital. So this, again, can be a confounder. And then even more importantly, if you look at the number of people who dropped out of the trial during the trial, there was quite a number of people who dropped out in the treatment side, but nobody dropped out in the control side. Now, this could heavily skew the results. Now, I'm not necessarily saying that chloroquine does not work. I mean, it may very well work, but I think we really have to be very careful when we look even at clinical trial data, even though they have a treatment arm and a control arm. So I think there are many examples. I mean, for example, there's a study on favipiravir. Again, if you look at the details, you find lots of problems. I mean, just specifically, one of the favipiravir trials from China, less than half of the patients are confirmed virologically. What were the other half? I mean, if they have a flu, of course, favipiravir would work. So I think just to point out that you really have to look very carefully at clinical trials. Thank you. Over.
Okay, thank you. And while we have you here, there's a follow-up to the earlier question, Malik, about deaths, where somebody's asking, could you talk specifically about what treatment they're using in Hong Kong? Do we know what treatment they're using, and is it effective? Is that one reason why they're able to save people?
Well, like I said, I think it's a bit premature to jump to that conclusion. But nevertheless, I mean, there are a number of treatment protocols that are being used. I mean, one is Calitra, which is a HIV drug, which, of course, you know, back in the time of SARS was later on came into use. And it is used in combination with interferon. If the patient presents early, but if the patient presents late, then it's Calitra without interferon. So there are a number of different strategies that are being used, but I would hesitate to jump to any conclusions that the case fatality rates are necessarily due to that. The differences in case fatality rates are due to that. Over.
Okay, thank you. And we'll just give you a break there, Malik. We'll jump to Professor Kajimoto, because I see one directly from him, which is asking just how much of a public service role do you think journalists should play in this epidemic? And one of the tips given by the fact-checking organizations discourage reporting on the worst-case scenarios. However, the media can raise awareness by reporting on these worst-case scenarios. So it's a difficult balance to walk between raising too much alarm or not enough. What should journalists do in that case? And please, anybody else can jump in as well.
Well, I think one of the reasons why we are having this kind of panel is to rethink what public health communication should be, and journalists should be working with experts to understand how to frame the messaging. And that's really important. In other words, I believe that news media's role is really big in communicating health science to the general public. Worst case scenario, yes, I can understand that that's something that people are thinking about. Therefore, journalists' obligation is to ask the questions that public is probably want to know. But having said that, I think that shouldn't be the news angle. If you ask experts the worst case scenario, that shouldn't be in the headline, that shouldn't be in the lead or first paragraph. That could be add-on information at the end of your article, at the end of your TV show, but not you shouldn't start with that. I think that's sensationalism. Yes, worst case scenario can be like this, but to reach that point, there are so many other things we can do, and this is what experts said. So I think that should be the lead. So I think the way you structure your news story can make a big difference.
KG, are you there with? Would you like to weigh in on that from the expert side as well? I mean, when we get these models that could show up to 20 million dead or whatever, I mean, how should journalists deal with that? You don't want to alarm people, but you also want to not bury what is news. And unmute your mic there.
Sorry, I think there's a couple things for everyone to know. I mean, journalists are like everybody. They're in competition with each other for stories. And, public health messages are often boring. They're sober, they're to the point, and they are what basically health authorities in most places would be repeating. And it is a little bit going against what journalists are doing. But I think that, what Masato is saying was really a good point. I think that every journalist covering this story is a public health proponent or is somebody who is perhaps creating fears out there too. And I think to be sober and, really to make sure that your story has a balanced perspective. I think a lot of times it's hard to know what is the quote unquote truth, but it is possible to make sure that the story has a balanced perspective and is not misleading in, hopefully unintentional ways. But yeah, it's one of the things I think that journalists can do. Over.
Yeah, thank you very much for that. While we're getting some more questions, I had one other question that came up well during a couple of the presentations, because we talked about the incubation phase when you first got the virus, and then the phase when when you're infectious, when you can actually infect other people. My question is, if you think you may have been exposed and you might be, you're not sure, you may have been near someone coughing, is there anything that you can do to limit your viral load or limit you going into that infectious stage? Is there any over-the-counter drug you should be taking? Or Masato has already told us drinking water won't help. So if you actually think you might have gotten exposed to the virus, is there anything you could personally do other than just waiting and seeing? Does anybody want to take that?
Yeah, I mean, let me get started. There's
please.
nothing magical that you can do to ward off your chances of getting infected if you've been potentially exposed. But I think the whole point of all of the recommendations which are made out there about being prudent about social distancing, about using personal hygiene methods, to wash your hands and so on. And if by chance you do get symptomatic, to make sure that you don't expose others unnecessarily. I think these are the main points and main things that people can do.
Anyone else on that question? Is there anything else you can do other than avoiding someone who is infected? Is there anything you can do? There's no over-the-counter drugs you should douse yourself with or anything like that. That's correct. Okay. Let's see what else is who else. We got one question here that I think this was for Professor Cowling. You've mentioned in your estimate that there are actually more than 230,000 infected cases, possibly in mainland China. Would you mind explaining a little bit more with why you believe that, or where that number might come from?
Yeah, sure. So we know that there always will be more infections than cases, because not every infected person will be identified as having been infected. So there's a certain number of cases. There will always be more infections than that, but it's not necessarily a lot more. What we know about coronavirus is that there's a big chance of having an asymptomatic infection rather than a symptomatic infection. We've seen reports that maybe 10% or even more than that of infections are asymptomatic among close contacts that are observed. I think in the Diamond Princess ship, it was more than 10% asymptomatic. And so we know that in China, the asymptomatic the people with asymptomatic infection are not counted as cases. So we can already add on top those. And then we also know that there must have been people with milder illnesses who were not considered to be cases and not investigated and not tested. So that's why I think there'll be more infections than cases, but I couldn't say how many more. What we would really need to do is a serological study to look at antibody levels maybe in Wuhan or somewhere else. Over.
Okay, thank you. And here's a question for Mary Hui at Quartz to Professor Paris. A very detailed question. I'll try to get it as accurately as I can. If we have, she said you wrote, Professor Paris, in a 2005 article in Nature that the renin-angiotensin system was important for lung damage in SARS. Do you think there is scope to treat COVID-19 with the receptor blockers, ARBs, as was suggested for SARS? And can you comment about the current disagreement over whether patients who are on ARBs should be maintained on ARBs?
All right, so that is true. So the paper we wrote back then in regard to SARS was one of the mechanisms by which SARS caused acute lung injury and severe disease, and that was of course in a mouse model, and there was a mechanistic explanation for that. Whether the same applies with the new virus, the SARS coronavirus 2, is left to be seen. I mean, I think once we do have animal models, which are now just becoming available, clearly these are some things that we would address. Now, regarding people who are on antihypertensive medication, ACE2 blockers, etc. I mean, I think I wouldn't be competent to really address that, but I think I did see opinion piece written recently suggesting that that is something that needs to be looked at. I mean, many of the other hypertensives are no problem, but the ACE2 inhibitors may have some issues. So I would really, refer that to my clinical colleagues. Over.
Any clinical colleagues want to add to that at all? Okay, and we have one question here for everyone, or for anyone who wants to pick it up. Maybe you, Malik, if you're going to continue. It says, as mentioned earlier, our RNA virus won't mutate as frequently as influenza. And how can we interpret this situation? In Iceland, an individual appeared to be infected by 2 strains of coronavirus, and one of them was this original novel coronavirus. I'm not sure about that case in Iceland. Are you familiar with that?
Yes, I haven't seen the details of the case in Iceland, but as I mentioned, I mean, although the mutation rates in coronavirus is not as high as with flu, I mean, clearly these viruses do change, and therefore they have signatures of differences, right? Now, a few weeks ago, there was a lot of excitement about 2 strains, one being more severe than the other, etc. I don't think that has really held up. I mean, of course, you might see this, for example, in Wuhan, if you have one lineage that is expanding, it might appear that that is looking more severe, but there are many other explanations for why, case fatality in Wuhan might be much higher than in other places, even in China, which was the case, right? So at the moment, we really don't have any clear evidence for differences in virulence or transmission with these mutations that are appearing. Now, the possibility of getting infected by 2 strains, of course, is uncommon, but it's possible. I mean, we know this sometimes can happen with flu. You can get infected from 2 sources, and then the 2 sources each may have a different genetic signature. So that doesn't necessarily mean that, one way or the other about the severity. Over.
Thank you for that. If no one else wants to jump in, we have a really interesting question. It's about Hong Kong, but I think it's something that's on everybody's mind, from Elizabeth Chung. She asked it to Professor Cowling or Professor Wu, if you want to jump in. It says, with the current growth rate of cases in Hong Kong, when do you expect to see that we reach the peak in Hong Kong, and when will we start seeing the decline?
This is Ben Cowling. I don't think we've really started on an epidemic trajectory yet. I think we're in the very early stages of what could turn out to be a first wave, but hopefully doesn't. So I'm really hoping we don't even start towards a peak, let alone reach a peak, because there'd be an enormous health impact if we did go in that direction. At the moment, most of the cases we're seeing in Hong Kong are coming from overseas, and we're able to reduce the transmission into the community, and we hope that's going to continue. Over.
Okay, anyone else want to jump in there? And if not, we have another question here, which from Dennis, who's asking for Professor Cowling or Dr. Fukuda, either one, saying regarding social distancing, are there any studies that assess different levels of risk for different distancing efforts? Closing schools and canceling mass events is pretty clear, but what about riding the metro or the bus or shopping for groceries? In the US, some supermarkets have special hours for senior shoppers, for example. I mean, how are we doing social? I mean, every country seems to have different idea of what social distancing is or does. How do we know what's effective and what's not, I guess, is kind of the point of that question. KG, do you want to try?
Yeah, I think, I think this is one of the big questions for everybody right now. I mean, in essence, we see a large cocktail of different social distancing measures, in part because we live differently in different places. So, you close one thing if you have it, perhaps. But I think that basically, Ben may know of empiric data, but I don't know of any good studies which is really able to quantify that one approach to social distancing is better than to another right now. But Ben, you may know more.
No, I think there's a lot of data for influenza, and then we know, for example, school closures are really particularly effective for influenza, but we don't have any kind of similar evidence base for coronavirus because it's so new, and there's not a lot of things we can compare it to. So we just have to use our kind of mechanistic understanding of how spread's occurring, where it's occurring, and that would give us an idea of which kind of measures would be relatively more effective, but very limited evidence base.
And we had several questions. I'm going to try to lump them all together into one or two questions here, because we had several during the course of the presentation about masks, the effectiveness of having the entire population wear masks, as in Hong Kong or other countries are not requiring masks for various reasons. Some places say masks are not really effective unless you actually believe you are symptomatic and have the virus. Some places are doing that because they simply don't have enough masks for all the population. Can somebody just talk a little bit, about this whole idea of masks? And let me just add as my own caveat to that as well. Could that be a reason why we've seen the rate at least effectively contained more in Asian countries where more people are wearing masks, or is that irrelevant?
Yeah, this is Ben Cowling. I can talk a little bit about masks. I think the top priority for surgical face masks is for use in healthcare settings. And that's true everywhere in the world, because we believe that surgical masks do provide protection to healthcare workers to protect them against infection as part of a package of protective equipment and protective behaviors that will reduce their chance of getting infected in the hospital. I'm not clear why there's a different standard applied for use in the community, that somehow face masks are really, really, an important part of protection of medical workers, which I agree, but then somehow not effective at all in the general community because people in the community don't know how to wear masks properly. I think if that's really the case, then the solution is to have a public education campaign, not to avoid recommending the use of masks. It doesn't make sense to me to say that face masks have no effectiveness. Having said that, the randomized trials that have been done of face masks and hand hygiene in the community give pretty mixed results for both measures. So there's not a lot of evidence that hand hygiene has a big effect on transmission of respiratory viruses. There's not a lot of evidence that face masks will have a big effect on respiratory virus transmission. Maybe both measures will have a small effect, and we would like to have a number of measures applied, each of which have a small effect, because in combination, that would then be able to slow down transmission. For the specific case of Hong Kong, I think the biggest effect on reducing transmission in Hong Kong has been from the public health measures, including isolation and quarantine of contacts, isolation of cases, quarantine of contacts, and also the social distancing, a lot of people working at home, a lot of people staying at home, and avoiding mass gatherings and so on. Face masks may play a role, but not the most important role in protecting Hong Kong from an epidemic. Over.
Okay. If anyone else had any comments on masks, otherwise I've got just a couple more questions and I'll let you go.
Sorry,
please.
Yeah, this is Malik. I completely agree with what Ben said regarding masks. I think regarding hand hygiene, I think I just want to point out that as he said, effect of hand hygiene in influenza is pretty mixed, and there's no clear evidence. But I think we just need to keep in mind that coronaviruses, particularly this coronavirus and also SARS, is extremely stable in the environment. As I showed you the data, as we went along, it can last for days on, for example, steel surfaces. So I think as a precautionary principle, it certainly would make sense to emphasize hand hygiene. Over.
Okay, thank you very much for that. And just we'll do one more question from the batch here, and then I'll just maybe I'll just KG to help wrap up at the end here, since we're getting near the end of our time. I said we'd go 10 minutes over, but just some people was asking if we're going to see more cases in Hong Kong, if we're not at the peak, and officials might be considering just letting people with mild or no symptoms just stay at home and self-quarantine rather than hospitalization. Is that a practical approach at this stage, or should we be doing more of a containment strategy? So anybody who even tests positive is quarantined or contained away from neighborhoods, friends, and family. Anybody want to take that one? That was actually asked to Professor Cowling, but
yeah, I think I showed in one of my slides that isolation is taking place fairly not particularly quickly after symptom onset. So that will prevent someone with transmission, but not a lot. If the person was isolated at home instead, then I think there would be a greater chance of transmission at home. But maybe if there was going to be transmission, it might have already occurred at the point when we're currently deciding to isolate the people those patients in hospital. I think quarantine is probably a more important public health measure in terms of identifying people that might have already been infected and stopping them from spreading it further. But that's going to be more and more difficult as the case numbers increase. And we might need to look to social distancing measures really for containment rather than just the case-based finding. So we might have additional measures from the government strengthening the social distancing, like we've seen in the last week, for example. Over.
Okay, well, I want to thank, we've run out of time. We went 10 minutes over because we started a bit late because of some technical issues. So we are 10 minutes over past the hour of 1 now. And I do want to get these important people we have here back to work, helping us solve this problem. But I think talking to journalists is an important part of the work. And I really want to thank all the participants there. Before I turn it over to KG to close it off, I do want to remind you, you'll be getting a follow-up message from Jennifer, who set this up, just asking for your feedback for how we can make this better next time, if you would be interested in continuing this or broadening this or doing another version of this in the future. Or you could just email Jennifer as well, or myself, Keith Richburg, at richburg@hku.hk. Just let us know what you thought of this session, if this was valuable for you, how we can improve it for next time, etc. And so with that, I will turn it over to KG to just wrap it up, and you can just thank all the team on behalf of all of us at the HKU Journalism for helping pull this together.
Yeah, thanks, Keith. I first want to deeply thank the the panelists for taking time. They are literally working around the clock on the COVID situation and have blocked out the time for this. And then I also want to really point out that Jennifer, and then on the school, Fanny Leung, have been the two people that have really pulled this all together, and thank them. And just to add why we really hope to hear back from you, actually many of you are calling from different parts of the world. And so this is actually a global session right now. So it's in weird hours of the day for all of you. And it's a big amount of time for everybody to spend, on a call like this. But if it does make a difference and you find that it's useful, it would be helpful for us to understand how it's useful to you and what it is that we can do better. But if we do hear back, we're really committed on this side to trying to do our bit about helping everyone to understand the situation better. And then, as Masato was pointing out, how to talk about the situation, present it better. It's really important, because I think the confidence of communities and people and countries literally depend on how these issues are discussed and presented to the public. So with that, let me thank Keith, really Keith and Elizabeth for igniting this idea, and thanks everybody for joining the call, and thank you. See you later.
Well, thank you. Thank you, KG. Thank you for all the guests. I want to thank Elizabeth Chung from SCMP, if she's still there, because this was really her brainchild to put this all together. And of course, Jennifer Wang, and then our tech team, Roy and Carlock over at the HKU Journalism, who helped keep the Zoom running and getting everything going. Again, thank you all. Give us your feedback. Thank you to all the guests for taking so much time. It's really important to keep journalists informed of what you guys are doing and the expertise out there, so the journalists can then help keep the public informed. So again, this is the end of this meeting. I think it's being recorded. It will be on YouTube, watchable there as well. Just remind everybody that this was on the record if you needed to use anything out of it, except for the slides. Maybe just ask for permission there. Thanks very much. Jennifer, any last word?
No, I think we're all good. Thank you all again for attending, and thank you so much to all the professors and our guy Masato for taking precious time from their schedule to do this. And yes, please, all the reporters, please follow up with me if you have any questions particular to today's workshop or any feedback. Okay, thank you so much.
Okay, thank you. And everybody, please stay safe. Stay safe, stay apart. Take care.